Hello, good morning, everybody. It's my pleasure today to introduce you for dental technician Michele Temperani from Italy. First, I will say a few words about his activity. He's specialized in ceramic work. Just a second, sorry. Excuse me. He specialized in ceramic work in the United States, where he also attended courses held by the Tanaka Dental Technology and seminars held by Mr. Masahiro Kuwata at the University of Washington. Since 1990, he has been a co-owner with his brother of a full-service dental laboratory in Florence, where he exclusively manages the ceramic department. He's a member of the European Group for Dental Excellence, author of 6 textbooks, 9 chapters, and more than 250 scientific publications and abstracts in restorative dentistry. He also speaks at conferences and courses for continuing education and has co-authored articles in national and international publications. This today lecture for us is correct workflow for a predictable aesthetic success in fixed prosthesis. Mr. Temperani, when you are okay, please go.
Okay, I'll share my screen.
Yes, please.
Let's see if it works. Okay, here I am. And can I start?
Yes, please.
Okay. Hello, everyone. It's a little bit funny for me to speak in front of just the screen, but I know that somebody's over there on the other side. So thank you very much for hosting me in this beautiful conference. And yes, my title is Workflow Approach for the Predictable Aesthetic Success in Fixed Prosthesis. What I like to say by just checking on these pictures is that today, for sure, we can achieve an excellent results in the white and also in the pink area. That means we can, either way, dentist and dental technician, we can achieve a very high standard. And this standard, we can have it in simple cases and also in complex cases. What help today, we get a great help from new technologies and materials, but the most important thing that we have to keep in our mind is that nothing has changed, speaking of protocols. And we can find protocols in old books and new books. But the problem is also that what has not changed is the usual habit of bypassing these protocols. And when we bypass the protocols, we have problems. I like to show this in a simple case because usually it's, a wrong approach is we do it on everyday work. And I want to show you, especially for the dentist, what happened when we do something wrong. So this is a simple case. The dentist sent me 4 units, picture the models. I start working, so I make the crown. I have some pictures. I see the before intraoral picture. So I see that the patient has a pretty much bad case. So I know that no matter what, I will make something better. So I follow the rules. When you don't have much information, you just follow the basic rules. So transition line, the zenith in the right place, deep contact areas, embrasures, the gull wing style incisal edges. I do my work and I send it to the dentist. Then he put it in the mouth and then something is wrong. The teeth are crooked. So what did I do wrong? Hey man, You made wrong teeth. Were you drunk last night? No, I was not. The problem is that we as dental technicians, we work on a model. And our refinement, if you don't have anything, is the horizon. So we take in consideration the fact that we work with a horizon. So I make my teeth straight by looking at this line. So it's not my work that is tilted, it's the mouth of the patient that is not on the horizon. But usually what happens, the dentists say, well, not a big deal, just fix it. I'll send it back to you and I will tell you what to do. Just make it a little bit shorter on the right side, make it a little bit longer on the left side. And here comes the big problem. Because when we make teeth, especially when we make good looking teeth, we make the color, and the color is inside. Like in a natural tooth, what makes the three-dimensional look of a tooth, the mamelons, the blue effect, the transition lines, everything is in the dentin. So we build up the dentin first, and geometrically, this dentin has to be perfectly suited compared to the final work. So when you ask me to make a tooth longer and a shorter one, it's a big problem because, if you look at the picture on the left of the screen, the mamelons have to be precisely very close to the edge of the tooth. But if I have to make the tooth longer, all the colors and the skeleton of the tooth, it's in the wrong position. So I either make a bad work, a patchwork, or I have to destroy everything and start again. So what do I need to make this teeth right, even in a simple work like this one? Well, intraoral pictures are not helpful because they cannot give me the position of teeth. Because even in intraoral pictures where you don't have refinements, the dentist, when take the picture, he always put it on horizon. So I received this picture because when you take the picture inside the camera, you have a cross line and you look for the horizon, but instead the position of the teeth are twisted. So this kind of picture, intraoral picture, will give me a false information. So I don't have to look at that. What is very important is a dentolabial picture, because in a dentolabial pictures, I see the midline, and it's okay if it's not correct. You just tell me, look at the picture and it's not correct, make it more angled to the left or to the right. I see the teeth position compared to the vermilion line. Now, it doesn't matter if in the picture I have the teeth, the provisionals, bad looking teeth, good looking teeth, we can adjust because we have refinement. Now, how you do the best thing to give me though is not a dentolabial picture, but is the model of the teeth. So I need impression of the situation before we're gonna do the prep. So this is the most important information that you can give to the lab if you want to have and achieve correct work. Because what do I do? What do we do in the lab? We get the impression, we put it in articulator, and then we make a silicon index. In the silicon index, I can see and trace the lines, so to have the midline, and then I see the edge of the teeth. Now, I know that how I have to build up my teeth. So instead of going to the left, I will go following it. Also, if you do this kind of if you give me this kind of information, I will also have the functionalized area. And so you will spend less time in fixing your teeth in the mouth, the patient. So in a simple case, a correct workflow approach is, of course, a dentolabial picture. So I get also the emotion of the patient, but most important, the model of the situation. Okay, it's a status quo model. And I will do this, make a silicon index, I found out the functionalized area, I do my teeth, and then you finish the case in a very simple way and we'll have success. Now, speaking of large or more complex cases, then of course the workflow approach needs to be a little bit different because we have to take in consideration also some more aspects. One of the most important aspects in this case is to try to find out patient satisfaction. Because in complex cases, in a rehabilitative approach, we know how we start, but we don't know how we'll finish. And if the patient is not happy, that's going to be a problem. Now, what is patient satisfaction for a patient? If I was a patient, well, what do I want from you? I want a nice smile. It's like when I go to a restaurant, nice restaurant, what do I want? I want to eat good. I don't know what's in the back, I just want a nice smile. Now the question is, what makes a nice smile? And for me and for you, we in the field, we know what makes a nice smile. A smile is nice when teeth and gums are healthy, and of course they have to be in harmony with the entire face. What is very difficult is to understand what is harmony with the patient. Some patient can have different approach, and we have to find out this. So the good question is, what is a good workflow approach for making a smile in harmony with the entire face? Yes, but still fulfilling patient expectations. This is the most important thing that we dental technician needs to know. And the answer for me is to start with a simulation project. So you, in the office, you have to do a facial analysis and also understand patient request and then give this to me. Sometimes patients have different requests. Maybe they want to look like somebody they saw in a movie or in the magazines. So we have to try to make sure that we can do that. So we have to do a wax-up analysis. And then in the office, the dentist will transfer this wax-up as a mock-up in the patient mouth. And then you have a result. You can have patient approval, happy, or patient disapproval. It doesn't matter. Most important thing is to know what is the street to go. So if the patient doesn't like it, we don't do it. Better. Or maybe the patient did not like my job, you can change technician and do it with another technician, and maybe he will do something better. So this is very important. Therefore, in a treatment plan, dental treatment plan, the dentist knows that he has to do a wax-up and a mock-up. So when you do a wax-up and a mock-up, I know that you will study the facial analysis, you will do a facial analysis, and also you will look at the dental status. And what is very important is that this information needs to be shared with the lab. We need to know this. As I said before with my host, you as a dentist sometimes see the patient for months, maybe years. So you build up something, relation between you and them. We don't know nothing. So we get the model, and in 1 minute, we have to try to put in all the experience that you had with the patient. It's very impossible. So the best thing is to share your informations. Now, facial analysis, if we cannot see the patient, we need to have pictures. But here it's another important thing. The picture has to be in a perfect position. This kind of picture do not help me. A picture has to be orthogonal, because picture has two faces only. It's not a 3D picture. So you have to make it orthogonal, 90 degrees facing the patient. And a picture like this on the right side it's missing some parts, it's twisted, it's not a good help. Now, how to make a picture. I know that today Miladino Milov will speak, and he's a great photographer, and probably he's better than me in saying, how you're supposed to take a picture. So I will give this to him. What I want to say is that the lab communication for a WhatsApp that will allow you to have a good mock-up in a conformative, so simple case, analogic approach, we need a real-line impression. Very important, not alginate impression, but we need the real-line impression. A bite registration, some pictures, and of course, an idea of what you want, patient analysis. Now, what do? I get this information. I see the patient in the picture. It's a beautiful girl. Teeth are not that good. The dentist already told me the limitations. He wants to do 4 teeth. Maybe I share a little bit of my impression, my experience. I think that 4 teeth is not enough. We have to make 6. We discussed a little bit, that we agree with it to say, well, let's do a mock-up. So he sent me the model. I do the wax-up, give it to him. He makes a silicone index. And then I have a little movie just to show how important a mock-up can be, also to propose a case. If you have a real-line impression, and then I do a good wax-up, you can obtain a very nice mock-up in the mouth of the patient. And then you already have you can see if the patient likes it or not. She looks very happy, and that gives us more input. We know that we can do this work and change her smile, and we know that the final result is going to be perfect. So before, mock-up and finish work, all the same. Today we have digital. Digital approach is very interesting because it gives us a lot of opportunities. And in a WhatsApp mock-up, if you do use digital, we need the same things, same informations, just digital impression and digital bite registration. Then the rest is the same. Actually, I get the picture with a facial analysis, and it's nice in digital because instead of overlapping a model, I can overlap the picture with the digital impression. So I get all the informations. I can put everything on the software. I put the picture directly with the suggestion of the dentist, so I don't even forget what he's asking for. Then I overlap with the models, and I will do my wax-up here by seeing the face of the patient. This is very good. Well, with digital, we lose a little bit of skill, but we get a lot of precision for other things like this one. So I can make a digital wax-up, and then I can make a digital model. I can print it. Then the dentist will go back on analogic. He will make a mock-up, and again, we can see if the result is okay or not, if the patient likes it or not. Speaking of more complex cases, the so-called reorganized approach. If we do an analogic approach, well, I need the same information, maybe a little bit more. We need Facebook because we are doing an analog and reorganized approach. If we do a digital approach, in reorganized situation, we need the same thing. And in digital, it's going to be even easier because digital impression, digital bite registration, and digital Facebook, you do it. So there is not mistake when we give this information to the lab. So I like it digital. I will show you a case to see what a dental technician that gets the right information can put into this WhatsApp. And I'll do it with this case, which was a reorganized approach, complex case, pretty much analogic. It's easier for me to explain. I did it with Marko Jakovac in Croatia, and he's in Zagreb, and I'm in Florence, so we are very far away. So I did not get to see the patient, and I did not get to go in the office to see that. So, you know, we need to have a lot of information. And what you see now are the pictures that Marco sent me to try to give me the emotion and understand the patient. And you see it's a young boy with missing some teeth. He has a funny smile. And in this case, Marco, just because I live far away, even sent me a little movie so that I could understand the feeling of this guy. And you can see that he's pretty shy and he has a problem in smiling because he knows that he has a problem with his mouth. But by giving me this movie, I get involved with this patient, so I feel it. So he also sent me the RX because he's trying to let me know that he's missing a lot of teeth because he has a hypodontia. So when I will do the WhatsApp, I have to know that, if implants will go there or not. In this case, the guy, for I don't know the reason, but he could not have implants. So I know that he has these spaces, and I know that I can play with these spaces. So it is important to have an X-ray. Also, he's sending me these pictures to, highlight the problems in the front, to see the overall situation. And I understand he has a very deep bite. But I also understand that the doctor worked on his dimension. He changed it. He gave me a new vertical dimension. And of course, he sent me the information. So impressions and then all the bites. So I could do a WhatsApp. Now, how do I do the WhatsApp in the lab? First of all, I already know everything about the patient. I feel it. It's my friend now. And I look at these pictures and I choose the one that will help me the most. And I choose this one because it's the most natural smile. And that's where I see the problem that he has. He has a lot of black holes in the mouth. And because the picture is high quality, I can enlarge it. And also the picture is orthogonal. So any picture that I put next to it, it's always in the same position. Okay. And orthogonal is also the articulator. And here I want to say another word that, about articulators and the problem that sometimes we have with dental offices. The face bone must be parallel to the horizon for a specific reason, always. And that's why sometimes we hide that, we don't use the face bone because we're not sure that we are receiving the right information. It will not happen anymore in digital though, because you do that in a different way. And I will use some information from Mauro Fradiani's book, which is very nice, and you can go back and check what happened when you take a face bone. If you take the face bone on a horizontal plane, so you don't look at the eyes or you don't look at the ears, okay, but you just put it referring the horizon. When you give it to me, I will put it on articulator, which is always on a horizon. So the teeth of this patient are twisted, and are twisted in a patient mouth and on my articulator. But if you have the same case and for some reason you put the Facebook not on a horizon, and then you take the position of these twisted teeth, when you send it to me, and I will have to put it on the articulator, check my articulator, and check the arrow that you see on the right side. My articulator, it's always, articulators, not just mine, are always on a horizon. So when I will put this Facebook on the articulator, what happened is that it will twist. And so in the mouth, we have a bended teeth, and on articulator, I will have a straight. So I will work with the wrong situation. So it is very important to remind that the position has to be on a horizon. So anyway, let's go back to the patient. Now I have the picture, I have the articulator, I have the models, and I'm, emotionally touched by this case. So I look at my friend and I say, hey, you have lower teeth. We don't see them. So first thing we have to do, we have to put this lower teeth in the right position. And so I will do the build up of the wax up of the lower teeth, try to give a good speak curve and put these teeth in harmony with the vermilion line. And also I have to give a good Wilson's line. After that, I have to check the front. And he has a big diastema, he's missing one lateral, and has two baby teeth on the right side. It has a lateral and a canine. It will need to be changed. So here comes the skill of trying to put the right teeth in the same space. And then I check it. It is very important. Marco gave me a better vertical dimension. So that's why I could make teeth with a nice speak curve, and they have to work, of course. Then also his teeth, we could not see the lower teeth, so it walks up even there. And then as you see now, the mouth looks better. I mean, this is my thinking, of course, I will send this to Marco, and Marco will do a mock-up. And again, I will show you this movie because it shows you how important can be, again, a mock-up for, the decision of the patient to do or not to do the work. This is the first time he's seeing himself with teeth. Okay, the young lady was happy and smiling. He's crying, and this is very important because it means that we achieve our goals. And then, of course, I was supposed to have those pieces, but dental technicians always work in the back, so but that's okay. Now, if the mock-up has a success, then the dentist will go on a treatment plan, which is usually is in a prosthetic work. It's going to be about preparation, impression, training, and cementation, and therefore you will need provisionals. So we have to do the provisionals. Provisionals, again, we can do it in many ways. We can do it traditional, we can do it through CAD/CAM, we can make 3D printed or mill. Personally, I like a lot CAD/CAM provisionals because, first of all, they're very beautiful, and it is interesting because with a CAD-CAM, you have a project, and the project can be changed. This patient, I made his teeth, and I thought they were pretty good in his mouth. They look pretty, but you know, after a while, he starts sending. He's a friend of mine. He starts sending me these kind of funny videos that he was claiming that the teeth are too big. So we had to change this. Now, probably it's true because his real teeth had, you know, were kind of inclined, and I tried to make these teeth a little bit bigger. He didn't like them. So because they don't have to like, we don't have to like the teeth, but the patient has to like the teeth. We have to remake the provisionals. Now in digital, I can just get the project and do some little change, just twist the incisals in, and then re-mill it. So very simple and very fast. So for me, this is perfect. And he's more happy. I don't like these provisionals, but you know, the patient likes them, so perfect. He likes them, dentist likes them, I'm happy. Going back to our before patient, speaking of provisionals, another important thing about the provisionals is not just that they have to look good, but they have to work. So when the dentist put the provisional in the mouth, in this case, Marco made his own teeth, his own provisionals. But the point is that the patient already happy with the mock-up. But the important thing is that Marco made this provisional, checked the provisional, and changed little things, because we can make good work with articulator and everything, but you know, the best place to check the bite and the function is the mouth. So a little bit can be done by the erosion during the time that the patient holds the provisionals in the mouth, but most can be done by the dentist itself, by changing little things. And that's what Marco did. And at the end, patient is happy with the provisional, and these are functionalized provisionals, which is very important. So the provisionals looks pretty much like the wax up. And after the dentist did everything, and this wax up is done, the mock up is done, the provisional is done, then we get to the final work. And again, what do we need in the lab? Again, lab communication important is we need to share the data. And the new data is how this provisional works in the mouth. So the correct volumes and the reference points and lines now are into the provisionals. And so I need this provisional. And how do I get it? Well, I need the impression. So the model of functional eye provisional is the most important information that I need. So what do I need for final work? I need master impressions, impression of functionalized provisional, and cross registrations. Why cross registrations? Because we're going to do a cross mounting. So I get all the information. I mount the master models, but then I cross mounting the provisionals. And by doing so, I'll be able to see and follow the lines. So I have all the information that I need. I can see the curves, I can see the volumes. And then I will not have surprises. No more twisted teeth, but you know, they will be perfect. Perfect like what? Like the provisionals and like the mock-up. So our goal is to have this in an easy way, very, very easy way. Same line here, here, and here. And you know, this is not the best picture, but you know, it gives you an idea of the success of this work by following a good workflow approach. Even though we were very far away, I never saw the patient, and I never saw the dentist because he's in Zagreb and I'm in Florence. Patient satisfaction. Now, digital cross-mounting, it's another nice, interesting thing because we can do the same thing in digital. And it's even easier because the dentist will take the impressions and the bite registration for the master models, but also for provisionals. Then he sent me the files, and I can put these files together into the computer. And by making transparency, I see exactly where the provisional, so the lines are, and I can just follow that. It is very interesting. And once again, in digital, I can also put the picture with the information that the dentist give me. In this case, Marco said, follow the mock-up, it's nice, just follow that. So I get the impression, I put it in the computer, I have the picture, I have the mock-up, and I can do the final work in a very, very predictable way. So this is the final case, final teeth, but most important, the before, the mock-up provisionals, and the final work. And between mock-up and provisional and final work, we have pretty much the same. So that's what we want. Now, cross-mounting, we can do it also if the dentist works in analogic and we work in digital. It's not a big deal. So if the dentist sends me a case that is analogic, so he sends me impression and the picture, remember the picture must be orthogonal, I can transfer this on the computer to do the case. And it's important to have the picture because once again, if you look, the preparations are, twisted compared to the teeth, the regular teeth. So what I can do, I can transfer the picture into the computer, and then by putting those blue dots on, in this case, on the bicuspids, I can overlap the before situation to the new situation, and I can follow it. And I can provide the dentist with nice provisionals that, follow the expectation of the dentist. They need to be on that vermilion line, exactly like her teeth were. Then the dentist will use the provisional to do his, surgical work and everything. Then, because he's an analogic dentist, they will give me the impression of the functionalized provisionals. And it's important because I can see that this patient has, a big erosion bite, so the lingual part of the teeth, are being consumed a lot. This is a very important information that I will transfer in the computer. For me, it's very easy. And I can do the final work by following those informations so that the dentist will not have to grind anything. And once again, we have final work that, meet our expectations, but also the patient expectation. So in conclusion, so I think I'm in the right time. I think that today we can have a predictable aesthetic success either in simple cases, like in very complex ones, if we follow a correct workflow. And to do so, we have to know the workflow, we have to respect it, we have to have good communication, and of course, good comprehension. That's it, very simple. Before the end, I'd like to thank my mentors, the people that allow me to learn a lot, especially about these workflows. So first of all, Lara Stangasilovic, Marco Jakovac, very, very nice people, and Dr. Jon Nicolescu. If I know what I know, it's because of them. So thank you very much. And last but not least, thank you all for listening to me.
Thank you very much, Mr. Temperani, for your presentation. Very useful information. We have a few questions for you.
Okay.
First is, which means do you use for constructing the Wilson curve? What? Please.
Well, we have. I use the tools that we usually use in when we work on dentures. Of course, it's not a perfect Wilson curve, but again, we do, let's say, I do 90% of it. Then it has to be customized and checked in the mouth of the patient. So it's a 50-50 work with the dentist. But to be practical, I use the tools that we use in build up dentures.
Okay.
And,
thank you.
And probably, I know it's not a perfect answer, but I use experience.
Yes, that's very important. Okay, thank you. Another question is how do you program the condylar parameters, sagittal and Bennett, in digital situation?
The dentist gave it to me.
Okay. Okay.
I believe that whatever I do by myself, it will be wrong.
Okay.
So if I don't get any information, I will not use it. I will just go with a basic parameter. This is a very important question because, once again, we need the comprehension of the dentist. These are numbers that they have to come from you, from the dental office. We cannot improvise this kind of numbers. So without it, it's better to work.
Okay, thank you. So it's something to do us like doctors for you for a complex case.
Yes.
So another question is if the distance is not a problem, what do you prefer, digital or analog impression, or your workflow digital or analog? If the distance is not a problem.
If the distance is not a problem, at the moment I like both systems. Yes, analogic system, it's more human. We can see three-dimensional and we can do a better work, but sometimes in analog you cannot be as precise as digital. A digital impression, I can show you, even though we are very close, I can send you a screenshot and show you something that I don't like, and you can give me a lot of help. On models, it's good. Analog is good because I can transfer my emotion into an analog because our talent can be, more expressive. But speaking of precision, digital is getting really, really good and interesting. There's no mistakes in digital. In analog, you have to be really, really, really good.
Thank you. We had a short conversation before the live, and you told me how a technician see a case and how a doctor see a case. Can you explain us what do you mean about this?
Well, as I told you before, a dentist get to see the patient for many, many hours, days, sometimes months or years. The family relations and everything. So they know exactly what they want because when they do their study, they see the patient for many, many hours. Then you take an impression, you call me, and in 2 minutes, you want to transfer me those emotions. It's impossible. That's why, of course, as a dental technician, we need to learn to get those informations very quick, but it's very important that some information needs to be shared. So if you cannot see the patient, because I understand it's not possible all the time, we are in two different positions. But with pictures, with movie, today we can do so much. We can get involved. If we get involved, we understand better, and we'll be able to give you a better job. Then, of course, each one of us has his own skill, has his own talent, and that cannot be taught or learned. We cannot learn it, talent, but informations, technical things that we can, no matter what. So it is important that you try to explain us give us as many information as possible. So many good pictures, good information. So good pictures and good. Also remember that you call us when you're free, and we answer when we, no matter what. So maybe we are doing another work, and you call me and explain a big job, but I'm doing another thing. So the things get in here and get out this way. So we need to have a plan by talking more. We need a lot more information, especially today that patients are very demanding.
You answer me with this for next question, because question is what do you need from us? At least three things, mandatory three things for a case, except the impression or the tooth preparation. You told us what do you need.
Well, we need to do a project. Okay, in order to do a project, I need mandatory the picture of the face of the patient and orthogonal.
So picture is mandatory.
Picture
Pictures.
is mandatory. I need the picture. I need to understand the needs of the patients, and most important, the innermost needs. Because again, the patient will ask you nice teeth, but you have to understand what she wants really. What is nice teeth for her. Yesterday I was listening to Mauro Fradianis, and he's told that even initially, in other countries now, patients want this white teeth square. Okay, they don't want to see embrasures, they don't want to see that and that. So but we come from an old school where we try to make teeth that look like natural. But patients want something different. So we have to understand that. Because otherwise, I will make a tooth that will look natural. Patient now wants to have square teeth, white. And even when they say white, what do they want? What do they want? An A1 or they want a bleach 4? So it is very important to get these informations. So it's to have just give me a crown A1 in zirconia. It's not enough. I need to see the patient face and to know their innermost thoughts. Then we won't make mistakes. And of course, mandatory is the before situation, what is called the status quo. Okay, usually patients have teeth in the mouth when they come to the dentist. So give me those teeth.
Okay, the first situation you need, it's mandatory, pictures and a short story.
A short story and status quo.
Okay.
So I want the impression of the status quo. I don't think that the patient come to you with the teeth already prepped. They have something in the mouth. They can be bad or good. Doesn't matter. I have to have that. And then we will discuss on that. You tell me these teeth are not good because I want them longer. I want it shorter, 1 millimeter here, 1 millimeter there. But I need to know that. So I need to have something to, you have the patient, I have the model. So mandatory is model of status quo, a picture orthogonal of the face, and the innermost thoughts of the patient.
Okay. Thank you very much for your presentation, for your lecture, for your advice. We hope next year we will be together, not online. Like you said, the auditorium, it's very important for you like a speaker. But this time, this is the condition. Yes.
That's okay. We always learn new things. So
yes.
Digital is not just a digital impression or a digital tooth, but this is digital.
Digital, everything.
this is the good thing about the digital, you know.
Yes.
We were able to get together no matter what.
Thank you very much again.
So thank you. Thank you.
Hello, everybody. Once again, we have two doctors in next lectures. One of them is Cristian Rotaru, and the other is Mihai Sândulescu. A few words about them. Dr. Cristian Rotaru earned the specialty degree in oral and maxillofacial surgery in 2014, and the general doctor degree in 2013 from Carol Davila University. His private practice is limited to oral surgery, dental implants, hard and soft tissue augmentation, and also orthodontic surgery. He's an expert of the prestigious learning platform Dental XP and a member of SSR and SACD. Dr. Cristian Rotaru lectures are mainly focused on dental implants and bone and soft augmentation procedures. Few words about Dr. Mihai Sândulescu. Is a lecturer at the Department of Implant Prosthetic Rehabilitation at Carol Davila University. He's a trainer and speaker in oral implantology. He has a PhD in medicine and master in oral implantology. He's author of over 30 scientific articles published in international journals. The title of today's presentation is Aesthetic Management of the Transition Zone, Surgical Development versus Prosthetic Contouring. It's a debate. Doctors, when you are ready, the podium is yours. Please share your screen with us. Thank you.
Good morning, guys. Thank you so much, Cosmin, for your nice introduction. It's a pleasure to be here, and it's very nice that we can. You managed to get together so many people. You know, it's really amazing. So thank you for inviting us, and hopefully we'll have a good day. Okay.
Thank you, Cosmin and SSER, for the invitation. It's a great honor for us to be here today with you. So today, Mihai and myself will talk about the surgical procedures and prosthetic phases for developing and managing the transition zone in the aesthetic area. Nowadays, an implant-supported restoration in the frontal area has to be aesthetic. It is not enough anymore for a crown to just restore the function. So the development of the transition zone is very important for the aesthetic integration of the future implant supported crown. Our patients are more and more demanding with their treatment results. They ask for high aesthetics and also natural looking restorations. But before going into our lecture, let us introduce ourselves a little bit more. So we work together in Bucharest in a small boutique-like dental studio. We are 2 doctors working and also 4 members of the staff, so a pretty compact team. My practice is limited to surgery, and Mihai, with whom I was to dental school together, is also working on the faculty. I also work at Trident Clinic, where I also perform surgery under local general anesthesia in their OR. So going back to the lecture now, from the surgery standpoint, we have 2 different clinical scenarios to begin with: site preservation and site development. Site preservation means to maintain as much as possible the shape of the ridge after the extraction. So, what do we do with the socket after extraction? How can we limit the resorption of the ridge? If the local anatomical conditions are favorable, we could place and stabilize an immediate implant in the socket. But would this implant limit the bone resorption? Or we have the second alternative, that is to wait for the socket to heal and not place an immediate implant if we do not have favorable anatomical conditions, or we just don't need an implant there. For example, in the area of a future pontic. Would this approach give less resorption over time compared to the first one? And is there a way we could preserve the ridge both when we place an implant and when we don't place an implant? What we know from numerous studies that after extracting the tooth, we will have a remodeling of the alveolar ridge with possible unpleasant aesthetic outcomes, whether we talk about a single replacement or multiple teeth replacements. So, what is happening when we do extract a tooth? What is the reason for which the buccal plate is resorbing after the tooth is extracted? The buccal bone is developed from the same embryological origin as the tooth, so we can say that the buccal bone belongs to the tooth. And if the tooth is gone, then the buccal bone is gone. The ridge will collapse horizontally as much as up to 60% of its original volume, and this will have a negative impact on the aesthetics of our future restoration. And if we translate this loss in millimeters, we will see that the bone resorption varies between 2.5, which is the lower limit, and can go up to 6 millimeters. A concavity on the buccal side of 2.5 millimeters is seen as an area of collapsed tissue on the buccal aspect. And in this case, there is no implant there, it is just a pontic, and no socket preservation was done either.
In my opinion, if we only want, we can really do site preservation only if we conserve both the bone and the soft tissue contour. I don't know if it's working. Christy, can you click on the? Oh, okay, let's try now. Okay. I don't seem to advance the slide.
Yes, I see.
Can you highlight the?
It's not working at me also.
Click on the presentation.
Yeah, it's not working.
Well,
Okay.
I guess
I'm gonna stop the share and then I'll share again.
Okay, so the idea is that the only way, in my opinion, we can really do a site preservation if by conserving both the bone and the soft tissue contour. If we only do a socket preservation, it is very likely we will end up needing some soft tissue graft because all the free gingival margin will have collapsed. But let's take a look at this image. Yeah, it's working out. I'll just ask for just a second. Request remote control. Request. Sorry for the technical issues, guys, but it's always harder to work remote. You know, we work better.
You have control now. You have control now.
Okay, let's take a look at this image. Here, this is a close-up of a pontic site, the right maxillary canine. And I am controlling, but I cannot change the slide. Christy?
Yeah.
Can you advance? Okay.
Yes,
just click it. So
I'll advance the slides for you.
Okay. Okay.
So,
thank you. Thank you. If I need something, I'll just say click. Sorry, guys. So this is part of a big case, but it's a full mouth restoration, which was referred to me. But today we will only focus on this canine. So I took this picture on August, and the patient had just come to me, and the root had been extracted, I think, 1 week before. And look at the soft tissue here, and now look at the soft tissue 1 month later. And here, it's only 2 months post-extraction. Only 2 months, and we already have a huge horizontal defect. But that is not all. Let's get back to this beautiful image. For me, this is like past, present, and future in a single shot. Because here, where the ridge is completely resorbed, this is the past. This is the present when we just extract this canine, but also if we leave this socket like this will be the future of this socket also. And as Christy was saying, all this buccal bone will be lost if we leave it like this. All of it. We can try to limit this resorption by adding some bone graft, but we will not be able to conserve everything. So we will add an implant here, we will add some xenograft, and we will preserve some of it, maybe. Or maybe we can do a partial extraction and we will preserve it all. But my question is, what about the soft tissue? Because if we preserve the bone, will the soft tissue remain all there? And here is an image from another case. Can you click it? And just look at it. Just click a bit on the image. Everything has collapsed here. And this is just minutes after the extraction, because we remove the extraalveolar portion of the root, we remove the supraalveolar ligaments, and now all this soft tissue has no support and has just collapsed in under a half an hour. And the resorption of the buccal plate has not even begun yet, and we already have a defect here. And we all like how the soft tissue looks here. I would love to get only cases that look like this, and I just have to take the final impression and go on with it. And obviously, this is mainly due to bone management, to the extraction technique, to the implant placement, grafting, and so on. But you know what? This case here is similar. In this case, this is a thermal dentition. So we will have to remove all these teeth, and we will have to place implants and do some bone grafting and so on. And look at this beautiful profile of the gingiva. Look at this papilla here in the middle. This looks amazing. And we can almost imagine how great it will look after implant placement. But 2 months later, we get this. If you look closely, you can see that the volume around the implants is preserved due to the good management of the bone. But what is the difference? Did we do something wrong here? No, we didn't do anything wrong. We just didn't do anything. We didn't do an immediate provisional right after the surgery. And now all the soft tissue has collapsed, even though the bone has been managed correctly. And please advance. If we look at these two pictures, of course, these are two different patients. But here in the upper picture, you can see all the soft tissue is flat, everything is resorbed, and in this lower picture, we have a beautiful scalloped profile. What is the difference between the two? It's only the provisional restoration immediately after surgery.
Okay, so from Mihai's statement, we could understand that an immediate implant will not preserve the emergence profile, which is correct. But will the implant preserve the ridge volume? Will the implant by itself maintain the buccal architecture by preventing the bundle bone from resorption? Well, if the implant could give vascular supply to the bone, then maybe yes, but it doesn't. So it won't help at all. The implant will not prevent the imminent resorption of the bundle bone. The socket will continue its normal healing, and the implant will not stop the remodeling that is taking place after the extraction. So, by placing an immediate implant in the socket or not, we will have the same result, a collapsed ridge. In this case, an immediate implant was placed after extraction without socket management, without any bone graft or soft tissue graft to sustain the volume. So without any means of hiding the buccal physiological collapse. It appears this is not a very effective way of preserving the ridge volume. We see here an average of 3 to 3.5 millimeter resorption in 5 years time frame.
And this is a perfect example why we need all the pieces of the puzzles to fit together. Because in this case, all the buccal contour has been lost. And now the implant is not in the ideal position. And because of all these factors, we cannot even hope to get a good aesthetic result in the prosthetic phase.
So by comparison, this is an implant also placed immediately after extraction, but in this case, the buccal contour is better maintained. So what are the differentiating factors here that have better maintained these tissues in comparison with the previous example? Because they both are immediate implants. The difference is the slow resorbable bone graft and the soft tissue graft. So in this situation, by using bone and soft tissue, we are trying to compensate the loss, to maintain a volume, to fool the eye, and also to make our brain think there is no buccal plate resorption there, that the tissues are still there. So in this case, we see a 1 millimeter average loss in 5 years, and this loss is greater when the patient has a thin gingival morphotype, and is less when we have a thick gingival morphotype. This is the case in which we've kept a root fragment on the buccal side of the socket shield technique. This technique will give us the possibility of maintaining the buccal plate and consequently the ridge architecture and the keratinized gingiva. Because the root fragment will maintain the periodontal ligament intact. And so the vascular supply to the periodontal ligament will maintain the buccal plate. And the buccal plate will maintain the ridge architecture. The average loss in 5 years is just 0.37. So 3 times less than in the previous case. So, as a conclusion, who will maintain the buccal plate after extraction, the socket shield or the implant? The answer is the shield, not the implant. And in the previous case, the dual zone case, who will compensate the loss by fooling us into thinking the buccal bone is still there after extraction? The implant or the bone and tissue graft? And the answer is the bone graft and the connective tissue graft, not the implant. Because the implant is just osseointegrating, and that is all that it does. The socket shield technique takes into consideration the biological factors that lead to buccal plate resorption. And by doing so, is trying to solve the shortcomings of previous techniques. The idea of this technique is to try and maintain undisturbed the vascular supply to the bundle bone. By keeping the periodontal ligament intact, leaving a root fragment on the buccal side of the socket just to keep this ligament intact, fooling our body into thinking that the whole tooth is still there. True site preservation, as Mihai said, is about conserving both the bone and the overlying soft tissue. and is achieved by performing a socket shield and also an immediate provisional. The clinical steps for the preparation of the root fragment remains almost the same, with only small variation as they were described when this technique was first published in 2010. We have to section the tooth mediodistally. We then extract only the palatal fragment along with the tooth canal. So the implant by itself cannot prevent the bundle bone from resorption, cannot maintain the ridge architecture. But the position of the implant plays an equally important role in the prosthetic development of the future transition zone. The implant should be 3 to 4 millimeters below the gingival margin, palatally positioned, and the implant long axis should be on the incisal edge or better on the cingulum area. The prosthodontist will always face a challenge when these two are not correct. He has to work with what the surgeon gives him. So this is, if it is just 2 millimeters below the gingival margin, he will not have space to develop the emergence profile. And if it is too buccally displaced, screw retain is not an option anymore. So the limitations of his work are set before his work actually begins.
If I may add something here, what Christy said are the most important two factors when placing implants in the aesthetic zone. And every surgeon should know this, even if he is not the one doing the actual restorative work. While I would argue a bit about the incisal edge position of the implant, let's talk a little bit about the first rule, because I want to emphasize this. So we need the implant to be placed deep, 3 or even 4 millimeters below the gingival margin. But how do we measure it? Which is the gingival margin? The gingival margin after we extract the tooth, or the gingival margin of the future restoration? Because this is where we need to be extra careful. As Christy said, after the surgery is over, we cannot change this anymore. And this is a case we will show later on, a case in which we try to modify the soft tissue architecture, but we are still limited by the 3-dimensional placement of the implant, which, as we can see here, it's too shallow. It's only 2 millimeters below the gingival margin. And this is obviously not enough. But in this particular case, even if the implant would have been placed 1 millimeter deeper, it would still not be enough, because I need some symmetry with the other lateral. And I would have liked the zenith to be just a little bit higher, like 0.5 or even 1 millimeter more apical. In other words, the surgeon who placed the implants should have known the restorative plan in order to place the implant accordingly. But we will show this later on.
Okay, so first let's look at this case. This tooth is not restorable and has an indication for extraction. It also has a chronic periapical lesion and fenestration on the buccal side, as seen on this CBCT section. And the plan is to place an immediate implant with socket shield and also to address the periapical lesion surgically. We section this tooth mediodistally and we extract the palatal fragment, being careful to also remove the apical area of the root. We practice an aesthetic incision on the buccal side to remove the granuloma tissue, incision that is away from the papillae and the gingival margin, so that we don't leave any visible scars. A chronic inflammation is not a contraindication for placing implants, even if it's an immediate one. The survival rate of the implant in these cases is almost the same. So let's not mess the two, chronic and acute. Acute means pus, abscess, pain, and chronic means most of the time no pain, no pus, and no abscess. Sometimes we can also see a fistula, which is not a contraindication for placing an immediate implant. There is a distance here of about 2 millimeters between the shield and the implant that will be grafted with bovine bone just to give stability to the cloth. Is it necessary to bone graft this area or not? From my experience, I can say that this doesn't matter if we place bone graft here or not. I tend to graft if the distance is bigger than 2 millimeters between the implant and the tooth fragment, just to give a little stability to the cloth. And that is the only reason I do it. And if the distance is less than 2 millimeters, I don't graft, and the results are the same. But please don't confuse the two different situations in which we graft or not. If we have a socket shield case, it is not so important if we graft. The reason I graft is only to give stability to the cloth and not to prevent resorption. The shield will prevent the resorption. But it is mandatory to graft in post-extractional immediate implant placement with no socket shield. And in this instance, I graft to prevent the resorption, to maintain the volume. Otherwise, the ridge will collapse. So in these situations, it is mandatory to graft.
Okay, so once the implant is stable, we can go ahead and make an immediate provisional. I prefer to make this chairside. If you want, you can have them made by the dental laboratory, but what I found is that almost every time I need to make some adjustments. So in single implant cases, I just do them myself. And the idea is to make the subgingival part, this part here, as slim as possible in order to allow for the connective tissue to grow. But also, we need to make a convexity exactly at the point where it touches the free gingival margin in order to support it. So I do this by adding flowable composite or acrylic resin and then polish it as good as I can. Just to quickly show the steps, this is from a different case, but it's also a socket shield case. But the protocol is always the same. So I always use metal temporary abutments, and I place the temporary abutment on the implant. I reline a pre-made shell with acrylic or composite resin, and then I add flowable composite, trying to obtain this S shape here, with the convexity touching the free gingival margin. At this point, I do a try-in, and you can see here on the distal and on the buccal aspect of the crown, there is a gap between the gingival margin and our temporary crown. And if I will just leave this gap like this, the gingiva will collapse. So what I do now is I take some composite, some flowable composite, and I just place it there. And now I can see exactly where the gingival margin is. I remove the excess, I finish, I polish it, clean it very well, that's really important, and that's it. And this, coming back to our premolar, this is the crown immediately postal. We can see a little bit of pressure on the mesial papilla, and also you can see that I left some space for the distal papilla to fill in. 3 months later, everything looks stable, but we decided to wait 6 months in total for this case.
Yes, and this is the 6-month healing CBCT, in which we can see a complete healing of the apical lesion, and also we can see the root fragment attached to the buccal bone.
Which means we can start with the final restoration. This is how the crown looks 6 months later. And when I removed the crown, and this is the first time I removed this crown. This is the emergence profile we obtained with our provisional restoration. So, in my opinion, it doesn't matter how much time it takes to make and adjust the provisional restoration. It depends on your experience. It can take you 15 minutes, it can take you 30 minutes, it can take you an hour, but all this time is not lost. You don't spend time in that provisional restoration, you invest time in it. Because look at this tissue 6 months later without any other subsequent adjustments. So we just unscrew the provisional and we are ready for impression. This is an older case, so I use an analog technique. Nowadays, we do these cases digital. So in an analog workflow, I always use a custom impression abutment. Some say it's not really necessary. Others say if the soft tissue is stable, it will not collapse after you remove the provisional. But what I found is that you always get some degree of contraction of the soft tissue after you remove the provisional restoration, no matter how much time has passed since you uncovered that implant and you made the provision. So I prefer to be on the safe side. So I use a really simple technique. I'm sure all of you know it. I screw the provisional restoration on an implant analog, and I take some polysilicon, I place it around it, and after it sets, I remove the provisional, and I screw in the transfer abutment, the impression abutment, and I fill all this space between the polysilicon, the index, and the impression abutment with either flowable composite, if you have a good curing light and it can penetrate deep enough, or with acrylic resin. In our case here, I use acrylic resin. This is a quick tip I can give you. If you notice here, I did a marking with a pen, and I mark which is the buccal side, because once you remove it from the silicone index, you might find difficulty to adjust exactly on the buccal side. And when I try in this impression abutment, we need to observe really closely the soft tissue, and we should not see any pressure areas. You should not see any blanching of the soft tissue. And this is the impression, and now our job is done. In fact, the job of the restorative dentist is done the second we make the provisional restoration. What we do now is just transfer the emergence profile we created to the dental laboratory, and we just ask the dental technician to copy it. And this here is a side-by-side comparison of the provisional and the final restoration in this case. And here we chose a porcelain fused to zirconia screw retain crown, and the dental technician was very careful to copy exactly the emergence profile we created. And this is how the final crown looks. And it's a nice result, but everything we see here above the gingival margin, it's only the merit of the dental technician. This is his job. It's not, we can say to the patient, okay, look, I made this beautiful crown for you, but we didn't do it. The dental technician did it. And what is below the free gingival margin is the merit of the surgeon, because the implant was placed in a good position and he maintained the volume of the ridge. And our merit as restorative dentists is only this transition zone. We just took care to preserve the emergence profile. I didn't create this profile. It was already there. I just took care of it. It's simple as that.
Yes, it is a team approach for sure. Prosthodontist, surgeon, and dental technician have to work together, because for an aesthetic result of our restoration in the aesthetic area, for harmony between the restoration and the neighboring teeth, we need that the gingiva to have a convex profile and to be keratinized, and these two things are controlled by the surgery. We need papillae, and the surgeon and the prosthodontist are both responsible for their presence. And as I already said, we need harmony between the transition zone and the rest of the teeth, which is fully controlled by the prosthodontist. This is a case in which we could not place an immediate implant because we didn't have enough apical bone to stabilize the implant. So we decided to place a delayed implant, but at the same time, we wanted to preserve the ridge architecture in order not to have the bone resorption and ridge remodeling that we normally see after extracting teeth. The reason for the extraction of the second bicuspid was a horizontal fracture associated with pain. So we have prepared the root the same way we did for the socket shield, and we have only extracted the palatal root. But although we prepare the shield the same way, we don't place the implant immediately. We just leave the socket to heal, and we don't use any socket preservation techniques that require using bone substitute materials either. We only use the root fragment on the buccal side of the socket to maintain the volume of the ridge. And after 2 months of healing, we raised a flap and placed the implant in a healed socket. So we could now stabilize the implant. The bone is seen between the shield and the implant. And this approach is known as the Glocker approach, in which we leave the socket to heal with just the shield on the buccal side, and we place a delayed implant. And this is the final result with almost perfect ridge architecture. One of the best and easiest solutions we have at hand nowadays for ridge preservation is to try and do only a partial extraction of the root, no matter if we place an immediate implant or not. Moving on now to the next case, this is an example of a surgical technique error combined with prosthetic errors that resulted in a complication. We decided to extract the tooth and do a socket shield with immediate implant. And on this CBCT section, we cannot see the buccal bone. It is very thin, and this is a major indication to do a socket shield because otherwise that bundle bone will be gone very fast and the ridge will collapse. If the buccal bone is thicker, we might have a chance of a smaller remodeling after the extraction of this tooth. But in cases with such thin bone, we don't stand a chance. So it is very important in such cases to try and do a partial extraction of the root. We prepared our shield and we placed the implant. Only after 3 weeks, the patient went to see the referring doctor complaining of gingival inflammation and bleeding on brushing at the site of the implant. So I asked the referring doctor to remove the crown and check if the adaptation is okay. After another 2 or 3 weeks, I get a call, this time around from the patient, who wishes to come and see me so that I could check if everything is okay, because she thinks something is still not right. And we can see the hyperplasia that was present on the gingival margin level. And this is the healing after 2 weeks. And all that I did here was to remove the crown and then put it back again in the same appointment. I didn't do anything to the subgingival shape of the crown, never touched it. I just took it out and put it back again. And what happened here was that the crown was not seated correctly on the implant the first time. And we can see here a comparison of the incisal edge position that is not in the same place before disconnecting the crown and after placing it again. All that I did here was to remove the crown and then placing it again correctly. The micro movements and the micro gap between the abutment and the implant caused this tissue inflammation. Once this connection is tightened and secured and there is no moving anymore, the tissue response is positive with complete healing. But things got more complicated than that, and after another month, I get a call from the doctor. I was abroad at that time, and he tells me that he made an appointment for the patient to get the final impression. And after the impression was taken, he again seated the crown in a wrong position. But this time around, the crown fell off completely after just 2 days. So I asked the doctor to call the patient and to get him as soon as possible in the office to place the provisional crown back in. But this didn't happen, and the patient went to the office after 3 days. The next day, after the provisional crown was placed again, I received this photo on my WhatsApp. And you can imagine that this was not the picture that I wanted to see. What happened here was that the doctor didn't give time to the soft tissue to adapt the crown again. He just took the crown, and by pushing hard, he squeezed this crown under local anesthesia back in through the collapsed tissue. Have you seen what happens to the soft tissue if we take out the healing cap for just 3 minutes? The tissue closes almost completely. Imagine what happened here after 3 days. So he didn't wait for the soft tissue to adapt again to the crown contours by slowly and progressively placing the crown back in. And because of the high pressure, the tissue became ischemic and then necrotic in that area. And this is the gingiva 1 day after placing the crown, and then at 1 week when the patient finally came to see me. At this point, though, the complication was managed both surgically and prosthetically. So we removed the crown, and with a burr, we reduced the subgingival part of the crown, giving enough space for the tissue to fill in and heal. Also, I have used a round diamond burr on a high-speed handpiece, and I reduced the root fragment crestally on the inner part of it, because part of this shield was exposed internally due to the pressure necrosis of the soft tissue that was between the root fragment and the subgingival part of the crown. And on the CBCT, you can appreciate how much I thinned the root fragment. But you can also appreciate that the shield was initially left too thick on the crestal part, and also it was 1 millimeter supracrestal. It should have been prepared at bone level, and also I should have beveled the inner part to create more space between the shield and the subgingival part of the crown. This surgical technique error, combined with the prosthetic-induced pressure on the soft tissue, resulted in the second complication that we had. And this is the 1 month healing with healthy tissue, and everything is stable now.
If I may, I want to add something here. This is a drawing I made. It's not really artistic, but I want to explain something. So this is a tooth that for some reason we want to replace with an implant. And we choose to do this with a socket shift technique. And as we showed in the beginning, can you click a bit? As we showed in the beginning, the implant needs to be placed deep. Christy, can you advance a bit?
Yeah, sorry.
The implant needs to be placed deep, and 3 or even 4 millimeters from the free gingival margin. This means that in most cases, it will be placed deeper than the shield. So we must be extra careful to make this portion here as concave as possible in order not to interfere with the shield, and not only not to interfere with it, but also leave enough space between the crown and the shield to grow some connective tissue. And any interference here might not allow the crown to sit completely, which happened in Christie's case, or it may even put pressure on the shield, which will lead to failure. So this contour here is critical for the success of this technique.
Yeah, so this is a few months later, no root exposure, no inflammation, and this is ready for impression.
Okay, but how do we manage more complex cases? Because all we've seen here, we've seen so far are single implant cases. Well, basically the same. We follow the same protocols, we just scale up. And this is a patient that was referred to us for the rehabilitation of the maxilla. And we can see there are many problems here, all prosthetic works and so on. But we also need to focus on the aspect of the soft tissue. And we can see here there is a lot of inflammation, and also here we can see some defects caused by the old pontics. This is the initial X-ray. I don't want to get into details of the surgery planning. I would like to focus on the prosthetic management. Because from a surgical point of view, things are pretty straightforward in cases like this one. And what I do, I like to take a step back and just look at the patient. These are the initial photographs. And starting from this, we transition to the digital smile design planning. You can help me with the transition. Okay. Because the DSD is not only for veneers. In this case, we use the digital smile design to establish the exact position of the frontal teeth in order to be able to position the implants. And remember what Christy said in the beginning of the presentation, we need the implants to be 3 or even 4 millimeters deeper than the gingival margin. So in this case, we need to raise the gingival margins from here to here, which means that the implants need to be even deeper, so 3 or 4 millimeters from the new gingival margin. Also, we can start to see we're going to have some problems here in the upper left quadrant. Next, we establish the new vertical dimension of occlusion. We do a wax up of the whole mouth, and then the dental technician can start to design the provisional restoration, and we can go ahead with the surgery. When we have full arch or full mouth cases, we always insert the implants and then insert the multi-unit abutments at the same surgical time. And we leave the multi-units there. And all the next prosthetic steps are done at the level of the multi-unit abutments. This is like the one abutment, one time concept. In this case, we didn't make a provisional restoration before surgery. So we just took an impression at the time of the surgery, we sent it to the lab, and this here is the PMMA bridge we received. And as I said earlier, almost every time I need to make adjustments to the provisional made in the lab. So we tried this PMMA on, and this is how it looks. We have no support here on the pontic sides, and we have too much pressure around the implants. Therefore, I take a pencil and I mark these spots here, and I start to remove material subgingivally to make this S-line, and I also add composite to the ovate pontics. Can you click? And this is what we end up with. As a comparison, This is what we receive from the lab, and this is not the dental technician's fault. These are the limitations of the CAD/CAM, because they need to have a certain thickness. But in the provisional phase, I don't care about the thickness of the material. It will hold. It's resistant enough. I only care about the soft tissue. So this is how it looks after I modified it. And intraorally, this is the provisional the patient left the office with. And you can see in these images here that I left some spaces there for the soft tissue to grow, because we want to try to conserve as much as we can, and also we need to give space for the soft tissue to grow. How much will it grow? We will just see in a few months. So our patient doesn't live in Romania, she lives abroad, and she can only come to Romania every 4 to 6 months. This is the X-ray 4 months later. And this is the soft tissue after 4 months. As a comparison, on the upper right part, the gingiva is starting to look okay, apart from the inflammation caused by the patient's hygiene. On the left side, though, we can definitely see some improvement, but not as much as I would like. And this is how the maxillary arch looks 4 months post-operatively. This is the first time we remove the provisional. And now let's go back a little bit to the left incisor. Why does this side look different than the others? Let's take a look how we started. This is the reason here. This defect, which was made by the old pontic, the old bridge which was moving when the patient was biting, it's exactly on the side of tooth 2.2, which means that just preserving the emergence profile is not enough, because there was nothing to preserve here. And this is why we need to surgically enhance this site.
So in order to make this site look better, we decided to use a connective tissue graft taken from the tuberosity and to place it through an apical incision on the buccal side. We prepared the flap split thickness, leaving the periosteum on the bone. And we have to make sure to completely and freely mobilize the flap in order to have to not have any tension, because any tension would mean that the graft could not reach the desired position.
After Christy finished the surgery, I reduced the pontic here in order not to put any pressure on the new graft and let the tissue grow. In a way, if you think about it, it's a step back in the treatment. But 4 months later, we can definitely see an improvement. And this is the right part here. The inflammation has reduced, and as a sign, as the patient started to get used to the hygiene protocol. Please click. And on the left side, it looks like we're on the right track. As a comparison, we can definitely see an improvement on the buccal contour. And this is the reason why I like to make many pictures, and I like to go back and look at the situations in every single step. Because we can see here that the distal papilla has not grown so much. It's starting to look good on the mesial, but the distal not so much. But we have solutions for that. Now the upper arch looks like this. And we can see that the scalloped shape of the profile is starting to take form. Here on this detailed image, you can see that the graft is well integrated, but the ovate pontic is gone because we reduced the provisional. And now we have to start to make it back. And for these full arch or full mouth cases, I always use a gingival index. So I copy the contour of the provisional restoration in a silicone model with implant analogs in it. And this way, I can start to shape the pontic site to make it look exactly as I want it to look. I can check it on the provisional, and you can see here it's a gap. And now I can add some acrylic resin on the temporary. I can screw it in the implant analogs, and now I will have the pressure on the soft tissue exactly where I want it to be. This is how the temporary looks. After I place the acrylic, we need to polish it and remove the excess. And here it's intraoral. You can notice some blanching here on the distal papilla. I'm pressing on it because I want to shape it now. The graft is integrated. Now we can start to work with it. And at this point, the patient wasn't really understanding where I was going with all this, because she was actually happy with this provision. She was saying, "Yeah, what are you doing? It's okay." And I said, "I can make it a little bit better." So at her next visit, a few months later, the site of the lateral incisor was okay. We had the good distal papilla because we put pressure on it with the provisional. So we're ready for the final impression. And of course, again, since this is an analog impression, I like to customize the impression abutments, but we don't do this customization like in the previous case. We don't place around the provisional. We copy with the gingival index, and we place the impression abutments on the gingival index. And now we split them and we copy the gingival profile with self-curing resin, and then I separate each impression abutment and I place every single one in the patient mouth. And this is the impression. You can see that I copied the gingival profile in hard resin, so it doesn't have time to collapse, and this gives us time to work. And please advance. This is the final work. For financial reasons, we went for a digital workflow and we delivered a full zirconia restoration. It's not the most aesthetic material, but it's the most tissue friendly. And this is a close-up of the site where Christy did the connective tissue graft. We can barely see there was a big defect here, but honestly, these details don't really matter for the patient. And this is what matters for the patient. This is the look that she wants. And this is the bigger picture. She doesn't really care about the distal papilla or the buccal volume of the left lateral incisor. She's just happy with her smile.
Okay, so we have talked until now about how to preserve the tissue, how to not lose the ridge volume and architecture after we extract teeth. But what about the situation in which we don't have tissues at all? Site development is when we have to perform bone and tissue augmentation procedures in compromised sites. And in these cases, we have to recreate the lost volume of the ridge. We have to rebuild the ridge architecture in order for the prosthodontist to have close to ideal alveolar ridge. When we only have a soft tissue problem in the aesthetic area, lack of volume on the buccal side, we can try to use an apically repositioned flap from the palate. This can be done either at implant placement or at implant uncovery. And the advantage of this flap is the advantage of this flap in the aesthetic area is that it will end up after healing with a gingiva that will look the same with the surrounding tissue. And also that the donor site is in the same surgical area as the recipient site. So less morbidity for the patient. We can also perform a connective tissue graft in order to boost the gingival biotype from a thinner one to a thicker one that will not only protect the bone, but also will give us a more natural and pleasing look of the ridge, transforming a concave ridge shape into a convex shape. The thickness of the gingiva plays a crucial role on the stability of the bone around implants. If it is less than 2 millimeters, a crestal bone loss of up to 1.45 millimeters may occur. So imagine that you managed to obtain 2 millimeter width of bone on the buccal side after a successful bone augmentation, which is more than enough for the stability over time. But this bone will resorb over time if you only have a gingiva that is less than 2 millimeters in thickness. So being able to obtain enough height and thickness of the gingiva and then to manipulate this tissue pre-prosthetic and also prosthetically are the most important aspects we need to take into consideration once our bone graft has succeeded and we have enough bone to place implants. A thicker soft tissue can protect our implant even if we have thin bone around the implant, or the implant is not placed in an ideal position. But a thin gingival morphotype can get us into trouble in the long run, even if we were able to obtain enough thick bone around an ideal implant position.
And talking about the thin gingival morphotype, this case here was referred to us only for the restorative part. And this is a close-up of, can you click again? This is a close-up of the case. This patient was finishing with the orthodontic treatment, and she was referred to us for the restoration of the missing right lateral incisor. But when we look at this case from the side, we can see that there is a huge concavity here. So in this case, this was not caused by the extraction of the root. This was caused by the congenital absence of the natural root. And if we look from the incisal edge, and I really like this view in aesthetic cases because it gives a really thorough look of the gingival profile and gives us basically the whole picture with this huge defect here. The bad news is that the patient already had an implant there, but the good news is that the surgeon who placed the implants did a pretty decent job. First of all, the implant was chosen correctly because it's a narrow diameter implant. And when we look at the axis of the implant, the axis of the central and the axis of the canine, we can see that the implant is looks to be, at least radiographically, in a good position. So in the first stage, we plan to uncover the implant, make an immediate provisional because the patient really insisted on having an immediate provisional, and at the same time, do a connective tissue graft. And this is the same view, but without the brackets. And we can see the big concavity here compared to the other lateral. And also, this image here is really important for me because this is a picture I took that is centered on the lateral incisor. And we can see there is no papilla here. We don't have papilla on the mesial, we don't have papilla on the distal, everything is flat. But also, if you look carefully, we can see the cemento-enamel junction of the central incisor, which means there is a bone loss here. And this combined with a very thin gingival biotype, at this point, we need to be very careful what we promise to the patient, because we can try to make this look better, but we can't promise it will look perfect.
So we decided to do a connective soft tissue graft, and this graft was introduced through a remote apical incision. Although I did a crestal incision to place the provision, to have room to place the provisional crown immediate as the patient requested, I didn't want this graft to be inserted through this same crestal incision because I was not certain I could stabilize the graft on the buccal side very well. So I decided to insert the graft from the apical to have a better control on positioning the graft on this area from apical all the way to the crestal. If I would have introduced it from the crestal, I could run into the situation in which I will be able to stabilize it only crestally. The flap was partial thickness and the graft was taken from the tuberosity because the tuberosity is rich in dense connective tissue. And you can also see here that it was very easy to harvest from this patient's tuberosity area.
This is the provisional restoration that I did at the same appointment with the connective tissue graft. And at this particular implant system, I don't really like that they don't have the option for a metal temporary abutment. They only have this plastic, this PEEK temporary abutment. And while this is really nice from an aesthetic point of view because it's not metal, so it's white, it has a problem with the resistance. This is why they had to make this portion here thicker. It needs to have resistance because otherwise it will fracture. It's all plastic. So I don't really like this because it's a little bit thicker than I would like, but we'll have to work with this. So I made this immediate provisional, and this is the image. Can you click? This is the image immediately after the surgery. And you can see this provisional here is really slim, and we left a lot of space for the tissue to start to grow because this is the idea. Can you? Okay. And this is how it looks at 1 week. But this is not the final result. This is just the edema of the soft tissue that is filling these spaces. So we must not celebrate too fast, you know, because after a few months, this tissue graft was done in November, and I called the patient back to the office in December, somewhat around before the Christmas. And when she came back, this is how the tissue looks, and this is not looking so good. In another few weeks, we can see that the connective tissue graft is stable. It looks nice. We remove the crown and we try to see where we are, because at this point I was not really happy, and it was, I told you, before Christmas, it was not a very good result to go celebrate, no? And now you can see first that the implant is very shallow and there's nothing we can do here. But when we look at this papilla, we try to think about what Dennis Tarnow said. And Dennis Tarnow wrote one of the, in my opinion, one of the best studies in dentistry about the chances you will receive a papilla depending of the interproximal bone volume. And now what I did here is I modified the contact point, because the contact point, the lower portion of the contact point was too high, and I lowered it a little bit, so I will be exactly 5 millimeters from the contact point to the interproximal bone. I wrote it with a pencil, and I left it like this, and I think 1 month later, we are back on track. So the papilla is starting to fill this space, and as a comparison, from the end of the surgery to this point, I think we're back on track. So now we can start moving on to the final stage of the treatment, and this is the part I really like. Okay. this is the mock-up, and we took an impression, we sent it to the dental laboratory, and they did a nice wax-up, and I did this this mock-up. And I discussed it with the patient, and we agreed to change the shape of the other lateral incisor with a porcelain veneer and do the restoration on the implant. And if we look at this image here, we can see that we're starting to get a decent amount of volume, but if you look carefully, you can see that the texture of this area here of the peri-implant tissue is not quite there yet. And now we face another problem, because I want to prepare the natural incisor as little as possible in order to have enough space for the ceramic, because we need to change the color a little bit. So we will end up with a very thin lithium disilicate veneer. But the restoration on the implant will have a different substrate. So there may be a difference in translucency. So our dental technician, Relu Bleda, did a hybrid zirconia abutment cemented on a titanium base, and on top of it, he did a veneer exactly like the one on the other lateral. So now we ended up with two veneers, one on a natural tooth and one on the implant. Obviously, when we're dealing with veneers, we need complete isolation for cementation. And you know, this is the patient's every favorite step. And you can see here on the central incisor, the dam is split, because here we still have the contention, the wire on the palatal side, and that wire must remain there. Because always when you have a dental implant between natural teeth, on the long term, there is a chance that the natural tooth will migrate to the buccal. So this teeth should better remain with the contention. And this is the final result, 1 week post-cementation. Hopefully, the soft tissue will settle down nicely on the zirconia surface, and maybe in 6 to 12 months, we'll have a nice picture to post on our Instagram. And this is the lateral incisor that blended in quite nicely, thanks to our dental technician, Relu Bleda. But this is the picture I like best in this case, because this picture shows how much difference can the surgical enhancement make on the soft tissue. I'm not 100% sure we will get a perfect looking papilla in this case, but the buccal contour can imitate the shape of a natural tooth. And also, it's not only about the volume. The texture of the soft tissue is also important, and it can really make a difference in the aesthetic zone. But when we talk about site development, it's not always about the soft tissue.
Okay, so now we are moving on to the last case of this lecture, a case in which we had to perform bone and soft tissue augmentation procedure in order to rebuild the lost tissues. This is the situation at intake, with bone and soft tissue defect around that crown, and because of this loss, we have an uneven gingival margin and an unpleasant look of this restoration. At first appointment, we extracted the tooth, or what was left of it, and then we waited for the socket to heal. 3 months later, we can see the defect with the soft tissue concavity on the buccal side, and on the CBCT, we can appreciate the bone defect. So the first connective tissue graft from the tuberosity was performed in order to have a better quality of the overlying flap. We prepared our site for the future bone graft. The flap was partial thickness, and we waited 4 months for the healing. On the right image, you can see that after the healing, we ended up with a tissue hyperplasia, a hyperplastic reaction due to the graft from the tuberosity. This is the bone defect at the time of bone augmentation. In the right image, we can see the nasopalatine canal and the nerve that was pushed palatally. A very important and essential aspect for the success of our procedure is to be able to maintain the space for the grafted bone. We can use for this an autogenous cortical bone plate harvested from the external oblique line if we plan to go with a 100% autogenous bone augmentation, like in this case. We can harvest this with cortical plate with a disc, a piezo, or just a Lindemann burr. And whatever your preference might be for building bone, you have to make sure that you will use something that can maintain the space long term if there are no bone walls to sustain it, and that it will prevent any muscle pressure on the augmented bone, because this muscle pressure will reduce the volume of vital bone you will obtain in the end. The cortical plate is then split into two pieces using a diamond-coated disc on a straight handpiece. This is done to make it thinner at around 1 millimeter in thickness. We don't need more than 1 to 1.5 millimeter. If you use more than that, you will pack less autogenous bone chips in between the plate and the recipient side. This cortical plate is then screwed in at a distance from the bone, just to create a space in which we then pack some autogenous scraped bone. So we have to always use a minimum of 2 screws for the fixation of the cortical plate, sometimes 3 or 4, depending on how big the bone defect is or how big the cortical plate is. We use as many screws as it takes to completely immobilize the plate. These are 1.2 by 10 millimeters long screws, and we have to make sure that between the cortical plate and the recipient site, we have a space in which we pack autogenous chips. We always try to reduce the sharp edges using a big round diamond burr, because we don't want these sharp edges to perforate our flap during healing. And then the autogenous chips must be packed very well in this space in order to prevent any soft tissue invagination that may occur during healing. After 5 months of waiting, we can see the tissue healing and also the CBCT image. And this is the clinical image of the bone after the bone graft procedure. We can see that we have very good quality of bone and that the implant is completely surrounded by vital bone. And this is the second connective tissue taken from the tuberosity that was used on the crestal area only, and it was shaped around the healing abutment. So in order to enhance the tissue in this area, because we needed more volume in order to begin developing the emergence profile. And this is the provisional that was used for tissue sculpting. So although we were able to rebuild the lost volume of the ridge by bone and soft tissue augmentation procedure, we were still far away from achieving harmony between the implant-supported restorations and the rest of the neighboring teeth. And achieving this goal, this harmony, requested complete compliance from the patient with frequent checkups and many slight adjustments to the provisional. You can see that on the implant site, we see that we have more buccal volume than on the tooth side, and this is normal. This is what we wanted here, because we need more soft tissue around the implant than we need around teeth. We need at least 2 millimeters of soft tissue around an implant in order to protect the bone and to be more stable over time. And this is the final restoration with nice tissue integration. But in order to get here, it took almost 2 years of treatment.
Okay, so in the end, just a few take-home messages. So whenever possible, try to conserve what we have. It's always easier, it's more effective, and you will be like a hero for your patient. And if a tooth is not restorable, try to think if you can keep just the root or just a part of the root in order to preserve the rich architecture. And when you're planning an implant restoration, no matter if it's a single tooth or a full mouth, try to plan starting from the prosthetics. This way, you will always have a guide to follow, and in the end, there will be less compromises. I would like to thank all of you for your attention. Stay safe, keep your distance, but always remain together. These here are our contacts. So if you ever have any questions for me or for Christy, don't hesitate to drop a message. So stay safe, guys.
Thank you.
Thank you, doctors. Thank you for your presentation. Please stop share your screen. Thank you for your presentations and for your tips and tricks for impression and everything.
Thank you guys for being with us today.
Thank you. We have some question for you. First, I think it's for Dr. Sândulescu. When you create a papilla, how long do you keep the provisional crown in place?
Well, it depends when we start to do it. So if it's a case when we preserve what we have, the first at the implant placement, so I make a provisional crown, the first time I remove that crown is at least 4 months later. And then I can start to work on that papilla. Sometimes in big cases, we have to add composite, then remove, add again. So every single step of adding or removing composite, I leave the patients at least 2 weeks in place. Then I move to the next step. And after I consider that the profile is complete, I leave it for 2 months till I take the final impression, at least.
Okay, thank you. Thank you. The next question, I think it's for both of you. When you use socket shield technique, you respect the rule of 3 millimeters depth, or depends of situation? I think you, Dr. Sândulescu, mentioned 3 millimeters depth from gingival margin. But in the case of socket shield?
Well, it depends if it's in the aesthetic zone or not. So if we're talking about the aesthetic zone, that rule is really mandatory, because if you have less than that, you will not be able to do an emergence profile. And if the implant is deeper than 3 or 4 millimeters, you might end up losing some of the bone. So yeah, you should follow that, in my opinion.
Okay, so you told the Dr. Rotaru or the surgeon how depth the implant could be?
No, I don't tell him anything. He does what he wants. No, we discussed the case before. So if it's an aesthetic case, we first do a wax up and we do a mock-up. So in the aesthetic zone, we need to know where the final restoration will be. So either it's a wax up and a mock-up, and we do pictures and so on, or we do a DSD. And then we establish together, we look at the DSD, we look at the CBCT, and we establish what is the depth of the implant. And Christy may say, okay, I can do this, but I need to do, I don't know what type of graft, so I cannot do this, or we have to switch to non-socket shield, because socket shield is not something you can do every single day. It's very technically sensitive, and Christy can tell you more about this case selection.
Yes, I have a question for Dr. Rotaru. If you use socket shield technique, do you use soft tissue graft in the buccal?
No. There is no need for that, because the shield, the root fragment will maintain all that architecture. So you will not have any collapse of the ridge. So there is no need for augmenting this area. So there is no need for soft tissue graft on the buccal side or any bone graft in the gap in between the implant and the shield, because the shield will maintain, through the vascular supply of the periodontal ligament, will maintain all the ridge architecture. So there's no need for that. Oh, you can do it maybe if you have any tissue coloring from a root, I don't know, but not for maintaining the volume.
Okay, thank you. So that's all the question. Thank you guys for your presentation, for be part of this online congress.
Thank you for the invitation.
Thank you for having us.
Okay, thank you. I have some message for participants. If you want to address question for lecture, for a speaker, please connect the specific doctor. You have to go to back menu and log in and click on the doctor who wants to ask the question. The next speaker starting at 1 o'clock, it's Dr. Walter Devoto from Italy. We have a small break when you could visiting the expo area. You can drink a coffee or something. So 5 minutes before 1 o'clock, I will expect you in online here on the Congress. Thank you, doctors, again.
Thank you. Thank you. Bye.
live. Hello, everybody. Welcome back to our online congress. It's a great pleasure to introduce you the next speaker, Dr. Walter Devoto from Italy. I will say a few words about him. At the moment, he is a lecturer at the International University of Catalonia, Barcelona, for a postgraduate course in aesthetic dentistry. It's a visiting professor at the University de la Méditerranée in Marseille. He has been an active member of the Italian Academy of Conservative Dentistry since 1998 and an active member of the European Academy of Aesthetic Dentistry since 2002. He's a founder member of the Italian Academy of Aesthetic Dentistry and founder member of Style Italiano. Dr. Devoto is particularly interested in the field of conservative aesthetic restoration and is the author and co-author of various publications in specialized international journals. Today's presentation for us is Black is Not Back, the aesthetic treatment for dark teeth. Dr. Devoto, the podium is yours. Please share your screen with us. Thank you.
Thank you. Thank you very much, Cosmin. Okay. So
okay.
Thank you, and thank you for the organization of this Congress. And it is, of course, a bit strange to participate from a distance. But I'm happy because I knew a lot and I heard a lot about your success in as much as possible the inevitable trouble that still remain on the tooth itself. And last but not least, it's just important the white success or also the gum around the tooth. It is very important to stabilize our success. So I'm trying now to respond to all these questions and hopefully to give you some tips and tricks regarding this way of going. So first of all, we need to understand which are the causes of discolorations of a tooth. And we know that it can come from a trauma, it can be an endodontical trouble because of material that are inside. The cement, of course, that are used, they can create these discolorations. The materials as well, in anteriors as in posteriors, they can do some trouble again. And also sometimes caries can create a kind of discolorations. But the most important, of course, there are, of course, other trouble as well, but the most important, it is to understand how the pulp degenerations can really create the trouble itself, because from the trauma, as you see, we can have the rupture of blood vessels, and then this degeneration that is going on, creating some iron inside of the tooth itself, and in this way to give to the tooth this kind of color. So, first question, is bleaching always necessary? I mean, bleaching, it's a very simple procedure, and let me tell you, very old procedures, because we know that from our experience, from the experience on our patients, that it is a very welcome procedure. It is also simple, let's say, and we are thinking always that it is safe. I mean, in my opinion, bleaching, of course, it is something important and very important in a case like that one. This is a friend of mine that sent me these cases. He treated this very serious fluorosis for 6 months with external bleaching, and he got this success. And of course, the bleaching in such a situation, for me, it's absolutely necessary. I mean, it was quite impossible to restore teeth from this way, to screen or whatever. Now, after the bleaching, we can decide whatever. The patient that can stay this way, or we can go for any kind of better restoration, aesthetically speaking. But let's try to catch some details that maybe not everybody we wanted to put in our mind. First of all, I mean, bleaching is not forever. I mean, we know that there are relapse after months, and also in this recent paper, they says that after 9 months, of course, we don't have any more the success that we got at the beginning. But even much more important, it is to understand that it is not totally safe. This is a unpublished paper from my companion in crime, Professor Puptignano, and Professor Rossini from the University of Ancona, showing that, I mean, if we scan the enamel, the safe enamel, and if we go to treat those enamel with hydrogen peroxide or also with carbamide peroxide, as you see, the surface is not intact as before anymore. So we cannot perfectly say that it is a very safe procedures because it doesn't get effect on the enamel. So be very careful when you are choosing such solutions for your patients. And also, it's really important, in my opinion, to take care about the fact that we can create some trouble on the bone around and the gum around those teeth. So that's something that we must really take care very much, and for the future of for the healthy future of the teeth of our patients. So, of course, if I have a situation like that one, in which having a radiogram, I see that I cannot treat inside the tooth itself, I attack this situation with an external bleaching, and actually I prepare a kind of tank like that in which I will put, I will ask the patient to put the material that I give him to take home and to bleach himself from there. And here you see the results that we got after 20 days of treatment with some bleaching that the patient was putting inside of the plastic support for 1 week, palatally, and from 20 days palatally and vestibularly. Now, of course, from that moment, we can recreate our anatomy, adding some composite material and finalizing the results. And in such a way, I think that the bleaching itself, it is a perfect weapon in order to finalize situations in which we cannot do anything else because we don't have any opportunity to go inside into the tooth, and also because we have around safe and healthy teeth that we don't want to touch. Just a little addition of composite can solve the situation. But let's go instead to better understand which is the bleaching treatment tactics that I apply personally in my office when I have to treat a non-vital tooth. So first of all, try to make your choice with some bleaching rules, in my opinion. And actually, I fix 4 steps in order to try really to do not change any time all my procedure. So first of all, of course, I'll go for retreat the endo if needed to clean inside, because many times just cleaning I can get already the point in having a white back, let's say. The second point or second and a half, it is the bleaching procedure itself. Why do I put 2? Because sometimes 1 appointment is not enough, so we need a second appointment to finalize at the best the bleaching itself. The third point, it is the restoration, that there are some time to wait in order to finalize it. But the fourth point, in my opinion, is the crucial one. It is the most important, the maintenance of the results that you got it. So let's go to analyze one by one the steps very fast in order to give you some ideas around cavity cleaning, endo-reendo, endo-seal. And of course, you see from these pictures how important it is to clean inside, because many times the dark comes because somebody has forgotten to remove completely the pulp. So the small access, the ninja, let's say, accesses, in my opinion, it's something that I don't understand really very much. What is important after this, it is to start, if you want, the bleaching itself at this point, or to postpone in a second, but immediately to seal the access to the root with some glacionoma, for instance. I mean, the main trouble that we can have in a procedure of bleaching, it is the cervical reabsorptions. And this is something that if happened to you only one, you will remember for all your life. Actually, me, I got a trouble many years ago in a patient of mine in a central, and really this is the big unsuccess that I got in my career. And you remember forever, and from that moment you forget to bleach roots, and you are very attentive to use the bleaching also in such a procedure. So the second step is based on this that you read on the screen. Actually, the most important to make you understand for me, it is to bleach in office and to use some distilled water in order to clean inside in between our steps. So here there is the procedure in which I'm cleaning, I'm etching, I'm going inside with the material, and then I put some stable temporary restoration. It can be some RM, it can be some flowable material, but it's very important that the restoration must be very stable. And as I told you, I don't put any material for bleaching inside, because for me it's totally impossible to really check and to control what is going to be. I'm trying just to do myself in this way, then to check the patients, and then to decide the moment to restore. So all my bleaching is in the office. It will be inside and outside of the crown, but in the office. Very important. I don't put in my protocol any walk-in bleaching on non-vital tooth in that way. So this is the results that I got. Actually, when you start from a yellow color, it's much easier to get a good result. So try to select your cases accordingly to the need. And now from this point, it is just to go and to restore. So for the restoration, I waited kind of 15 days. And after that, this is my way of going with these patients. This is the pictures that I took before the bleaching, and this is the pictures after the bleaching with a filter to show me that I catch correctly the results and I finalized. So the restoration is quite simple to make in such a patients because the anatomy, it is very simple. But as I told you, the most important step is the fourth. The fourth, it is then in-house maintenance. I mean, I make an impression at the end of the restoration. I give to my patients the plastic support and with the tank on the tooth that I have bleached, and I'm asking the patient, giving him a syringe to bleach time by time, understanding himself if the tooth is gonna be dark. And I can tell you that this procedure that seems strange, it is very simple. Patients, they catch immediately when the tooth become a bit yellowish, and they adapt and they use a bit of the material, or they call me if they have no syringe, no material in the syringe anymore, and so on. So don't forget, very important, to fix this point in your treatment for a non-vital tooth if you want to bleach. So just to recap, the most important in this chapter, in my idea, is don't bleach when you don't need. I mean, there are just some teeth that are important to bleach. For others, we know very well that it will be a non-success. So we need to go to another procedure to cover the tooth with a veneer or whatever else. So don't try to get longer the bleaching procedure, because you are playing with a very fragile tooth that can be break or can be bad influenced during the time of waiting. Second, bleach in the clinic. I told you, very, very important. I cannot control the walk-in bleaching, let's say. If I bleach in my clinic, I can get the point, I can see better what's up, I can be very, very precise with the patients in the moment to restore. Third point, don't bleach the roots. I told you this is a very, very dangerous procedure. So it's not under your control. Even if you seal at the best, you can have trouble. And really, in my opinion, it is very crazy to try to bleach the roots themselves. Fourth point, don't risk. So this is just the main suggestion for you. Don't take risks just because you want to prove yourself that you are able to catch some of the results. Sometimes the results can be catched much simpler in the way that I'm going to show you later. Play fast and smart. That's another point in which I always try to challenge everybody. In my opinion, the best success you have in any treatment that are fast and smart, let's say. But and especially with the dark tooth, this is something that it's really important to put in your memory box. Don't try to bleach for a long time and non-vital tooth to let it open and then to risk a fracture or whatever else. The second point that I want to discuss you regards immediately the way to restore teeth. I see that there is a lot of confusion around about how to restore a vital or a non-vital tooth. And I guess that instead, with speaking about vital and non-vital, one close by each other, we are acting at the very same way. I mean, this a case that I treated many years ago, actually. I was the patient came to me after a trauma. I saw that one of the tooth, even if it was still restored inside, it got a pulpitis. So I treat endodontically this tooth, and then I was asked to replace the two restoration, one on a vital, the second on a non-vital tooth. As you see in these pictures, first of all, try to be smart and to find the same level, to put the same quantity of material on the two teeth. And after that, go and proceed with your layering technique as you wish, whatever, it's fine. But just to put in a note that I'm not gonna changing my way of going in restoring the vital tooth, which is the 11, or the non-vital tooth, which is the 21. So when I don't need, I don't put any support, because, for instance, in this case, I have all the enamel around. I mean, in the case that I showed you before, I put a post because that guy, it's a boxer, and of course I need to help him in having some basement for any future need. But in a situation like these patients, I was acting counting on the fact that having an enamel around is more than sufficient in order to finalize my solution. And also I have a second chance in this case to bleach inside if I need for the future. So this is actually what I do in my clinic in any situation, if we speak anterior or posterior. Just sometimes I put a post to support part of my restorations. And I think that this is not something to be ashamed. I mean, to see and to say that we don't need any more post today, in my opinion, it's a bit comic. I mean, a case like that, that patient has a serious period troubles in the mouth. I was asked to restore this tooth. When I clean and I bleach, I see that I have just this structure. And of course, for any future needs, maybe a crown, or if we stay the tooth in the mouth or whatever, having a post to put inside, it is not stupid. I mean, I don't think that it will reinforce this tooth, but it is the support for a future needs for the patients. And really, in my opinion, it's not unconservative in any sense, because as you see in my prep, I just remove part of the gutta percha. I prolonged my restoration with a fiber post, and tomorrow, if I need to prepare for a crown, I'm already in. So I don't need to think to anything else. For such a reason, I don't consider that I have to be ashamed to put a post in such a teeth. Moreover, today we know very well that we don't have any more border in between conservative and pros approach. I like very much this publication from Coran Meyerberg, a very elegant dentist, a friend of mine from Switzerland. He published this paper in 2006, showing that there is not contradiction also in placing veneers over non-vital teeth. And actually, this is my way of going. This is a patient in which I'm asked to replace one crown. I have two central non-vital. I have one lateral vital with a little restorations. I consider to restore all the frontal area, let's say, and this is the most important fact. So I don't feel myself to be very invasive in restoring also that 22, which is vital and safe, because in such a way I will reinforce better the other teeth. So you see, this is my procedure in transferring in the mouth the mock-up, and then this is the final restoration in which I replace the crown on the 12. I place the two veneer and on the two central, and I place one veneer on the lateral, make them much bulky and much more resistance. And actually this is on that way I can prepare, you see, through our mock-up. I can be really very precise. We know very well this procedure from many papers. This is the final results that I got at the time, and this is the situation after 15 years. You see that the gum is still in place at the perfection, and I feel that this way of going, it is really convinced me even more that I don't think different if I have to restore a vital tooth or a non-vital tooth. So to finalize this chapter, my suggestion for you: vital or not, same story, really same story. Today, I do not go crazy to keep the vitality of the tooth. Also in posterior, I can tell you, it's much more important the wall involved, the number of walls involved in the restoration, and to protect very thin cusps, in my opinion, even if we are speaking about a vital tooth or a non-vital. In the anterior, even it is the evidence that we are speaking about the same situation, I think it's very clear. The second point, it is regards the post. So don't be afraid, don't be ashamed to put a post, especially in an anterior tooth after endo. I mean, all the time that I have the doubt to put a post or not to put a post, my answer is, okay, I put a post. So you see, I'm very, very simple in such a decision, because this is something useful for a future need. I think that is much more invasive in the future to go inside to remove an old restoration and to put a post to prepare a crown than instead to prepare today. Third point, what is smart? To go for a single restoration or to think also to the next tooth if needed? I just want to show you this case. 17 years old, the girl came to me with this trouble. Of course, she didn't like this black tooth that the dentist has decided, her dentist had decided to remove. So if I decided to remove, of course, I need to go to see why. But the first is, my target is 17. I will make all my best to save this central, because I changed totally the prognosis of a smile in a 17-year-old girl if I remove this central. This came after a trauma, you see, so this tooth is shorter. Just to bleach, it is totally useless because this is not the procedure correct to go in that. And maybe I have to involve also the other central if I want to get the best aesthetic results and also to reinforce this teeth. So this is my idea. I mean, when I have a dark tooth like that, in the past I made all my efforts to prepare in order to cover him and not to touch the other central. So this is the idea. I mean, to prepare a veneer, but as you see, I was consuming totally the enamel. So this is not really smart at all. That's why I don't go this way anymore. And it is not conservative at all because, of course, we know very well that there is one kind of dentistry with enamel, one kind of dentistry without enamel. So my procedure today is totally different because if you see this experience that came to my office, unfortunately it was not my own prep. The patient came to me without one veneer that fell down, and he was telling me his story. You understand very well my point. You can make your best to prepare a single tooth, but it is a losing challenge. In any way, you are not conservative at all, and you are not aesthetic at all. I can challenge you anytime just with a single tooth. So don't be proud just in catching the point if you are lucky on a single, because if you want to be success, you need to consume more. And if you consume more, as you see in this tooth, you have only some little peripheral enamel. You don't have anymore anything else. And even if you go in try your best to create not just adhesion, but also mechanical areas to keep the veneer in place, you will be unsuccessful. So the best way, in my opinion, to go is that one, to make the tooth a bit bulky and then to add a veneer on the next one tooth. In this way, you can hide better, you can make those teeth much more resistant, much more bulky, and of course the prognosis will be even better. So I went to check this case. There was a perforation inside. That's why the old dentist, the previous dentist, has decided to remove the tooth. Me instead, I wanted to create a mock-up with my a wax up with my technician, asking him to go bulky. And you see, going bulky, I have to add something over the closer central. And then after I went for perio. Of course, I move up gum and bone in order to have the same length of the two teeth and also to see better where the perforation is and to seal the perforation from external, and this way to save the tooth itself. So the next step, the first step, it is the prep for the veneer. As you see, I fix the mock-up and I prep over that. At the end of the prep, as you see here on the bottom on the left, I haven't touched very much the central, really just superficially. So in this way, I can make the central affected much more bulky and much more resistant. And at the end, this is the post-op. This is after 6 months. Look at the gum, how it's gonna be. This is after 1 year. In a 4 appointment, in a timing of 4 hours, I got the point for these patients, in my opinion, in a good way. And I went for some composites. Here there are some 5 years follow-up. Why? Because if you take a look to this literature, I mean, there is always a kind of eruption of maxillary incisor that can continue until the 25 years old. So in my clinic, the rule is under 25 composite, because I still can modify the cervical area if needed. Over 25 ceramic, because of course I have a stability of the gum already fixed. So what are the thoughts regarding this chapter? First of all, try to go always pair 2 teeth, 2 centrals. In this way, you are much more conservative. Second, the result is much more predictable and it's not much more costly, let's say, expensive for the patients, because if I consider to make a mistakes and then to change my single veneer, to ask my technician to make another one, or maybe another one, or maybe I have trouble in cementation or whatever, I go faster in offering to my patient the second veneer, and that's it. I can tell you that in my 25 years experience, this is much more predictable and also cheaper for you as a dentist. Third, you are much more aesthetic, of course, but also the teeth, they are much more resistant because they are bulky, they are much more resistant. So I don't see really any way, any advantage to go for a single tooth, especially when you're speaking about the two centrals. And even more, when you have all the anterior, you can see that this is a procedure even simpler and much more effective. In these patients, you see, I needed to go for different kind of restoration. I just went through the wax up. You see that I asked my technician to make a wax up additionally. And in this way also, I'm gonna changing a bit the shape of these teeth. And at the end, I try in the mock-up. I just prepare accordingly the mock-up. If there is material still on the teeth, it means that those teeth are untouched. And me, I'm more than happy when I see that. After that, I remove the rest of the mock-up. I take impression. I move to the lab. This is the procedure to create some composite veneers. And those are the 4 composite veneers that I bonded, and then instead I proceed directly over the 2 canines. And this way, I give a new smile to the patient, and if tomorrow there is any need, I can use this as a basement for new veneers or new crown, or I can remove, go for ortho, whatever. All it's possible because I worked additionally to make this teeth much bulky. Another very important point regards the material, which is the most important idea about that. It is important to use composite or better to use ceramic. I mean, sometimes I challenge my technician around this point, what is the best? And of course, ceramic, it wins always. I mean, in this, compared to composite, there is no chance, of course. But there are some situations, for instance, in this patient, I reimplanted these 2 teeth when he was 8 years old. And now he's, again, to my practice, he's 18 and he wants to cover these teeth. Of course, he has a kind of disease that he fall down very easy. For such a reason, I decided not to risk and to go for some composites. And in this way, I can screen these 2 teeth. I can make them much bulky without any prep, and using a material that tomorrow I can repair. So the only tips, it is ask your technician to be smart in creating an internal screen. And today we have some flowable, white, very opaque, that can really create such a screen. Don't go direct in such a situation because you are not able directly to make the same that is possible to make indirectly. So these veneers can be screened inside. We can speak about composite, and also ceramic veneers can be screened in a way. And at the end of the story, you see, this is my situation before, and this is after. Without any prep, I just made these teeth much more bulky and, of course, much more aesthetic. Of course, if I have an adult patient asking for the best aesthetic ever over these 2 non-vital teeth, my idea was to make a modification in the gum and then to go for 2 disilicates. And of course, the disilicate, it is a fantastic material as well to create the better aesthetic in such a situation. And with the polarized filter, you see even better the integration that you have in such a way. So the material is linked to the choice into the treatment plan. The most important, it is the profile of the material that you are creating. I mean, I love incredible this publication from Pascal Magne speaking about addictive contours of porcelain veneers. I mean, if you want to recreate the juvenility of the smile, we need to think that automatically we lose tissue growing because, I mean, we eat, because we kiss, because we brush our teeth. So the secret is not the material itself. The secret it is to go bulky and to have some profile as much bulky as possible in order to really to create the possible screen on your restoration. Then there are exceptions. I mean, this guy came to me, he's from Russia, with this tooth and with this post, and he's 25, 26, he doesn't have money for a real treatment plan, and he's asking me to fix this tooth. So I removed this strange post that was put inside. Then you see, just after the cleaning and the endo retreatment, you see that the result is already something nice without any bleaching or whatever else. So here the situation after my temporary build-up, that let's say temporary because I immediately build up in the first appointment in order to give the patient something better and also something more secure. Then we finalize the endo, and now we need to restore the tooth itself. So what is the best solution? To go with a veneer or to go with a direct? Veneer, the patient cannot afford. Direct, I cannot get the point in really covering perfectly the trouble because it's not predictable. So the idea it is, as you see, to put a post in order to having the opportunity in the future to go for something else. I'm removing the vestibular area in order to be paired with the addition, the next tooth that I will not touch, unfortunately. I tell you, unfortunately. And then I prepare, without any bonding, an addition of direct composite over this tooth. We call this, together with my companion in the office, Jordi Manauta, rural veneer, let's say. This is a funny name, but I think it works. As you see, I'm creating the veneer without bonding. What is the advantage? I see immediately the color, and I understand immediately if it will fit with the final outcome. I can finalize, I can shape at the best, and when everything's finished with a scaler, I can remove this veneer, I can finishing and polishing in my hands, and then I fix the rubber dam, I clean, I sandblast the surface with my Aqua Care, and then I go for the bonding procedure. I put some composite, the same composite inside of my veneer that I have prepared, and I cement. So this is the final outcome, and this is the situation after 1 week, which is not bad, and give it the opportunity to the patient for the future to go for something else. But at least I got the point at that moment. So to finalize this chapter, go for some semi-direct composites, or sometimes you can go for direct for a single tooth. But as I told you, this is difficult. It's not my first choice. Challenge yourself with the rural veneer because it's something very useful sometimes. Second point, go for indirect composite when a patient under 25. I told you, the cervical area, the way to be bulky in that area, it's very crucial, very important for many reasons. So be careful on this point. The third point, of course, if you have an adult patient that wants the best and doesn't have any trouble and so on, disilicate or ceramic, it is the ideal material. But to respond, you see, if it's better ceramic or composite, just is the way that you go through. If you go just with direct composite, asking company for something to hide some black tooth, you lose the chance because unfortunately, composite, it is a translucent material. It cannot really play at the best directly to cover the black coming from your tooth. Screen your layers. This is the only way that I understand in which I play with some direct composite. First of all, I play like a painters. The painters, they used to take a canvas, very, very white, or they put some white and then they put the color on that. So don't try to put some opaque yellow or whatever. Just go for something white and very opaque on the basement in order then to create your color over that. Of course, you need space, you need room. And this is the main trouble because you need to consume enamel. So this is the fact that we have already understood. Last but not least, it is the point how important is the gum in the strategies of bleaching. I mean, me, I don't put implants, but I know very well how to play over implants for an aesthetic reason. Here it is a 12 years follow-up. As you see, when I opened those implants, I decided to roll the flap vestibulary and to adapt at the best my healing cap in order to having a thick area of gum in that part, because the main trouble it is then to see that area thinner and maybe transparent, and maybe to see the implants underneath, or to have some black area coming. Same stories when you restore a non-vital tooth and you want to go for pros. The main point it is how to make the gum thick. And the temporary, they work incredible in order to lead the gum and in order to create this kind of screen. So the point is, the majority of the trouble for a dark tooth comes from the vestibular area in contact with the gum. So the main trick, the main important trick, it is to make the gum much thicker. I just show you this case that it came to me. She was very demanding, 31 girls, pretty one, very demanding for this lateral. Somebody was covering with some composite. The lateral was unvital, and not just the bleaching was the idea. I just saw that, as you see, it was a trauma, the story of a trauma, because the tooth is shorter. So my way will be to make this tooth longer, and of course, in such a procedure, to roll the flap in order to make it much thicker. If you have a chance, by the way, this is a book from Rufenack, a very elegant dentist from Switzerland, published in 1990. It's really the fundamental of aesthetic. You can see this, what today has been considered a news in this book already published. So really chapeau to this guy, and if you have a chance, buy this book. Or maybe you can find also on sale nowadays. Anyway, I roll the flap in order to make much thicker in this area. And here you see the healing of my situation. I remove the old composite. From now on, to bleach is totally useless. I need to wait at least for the healing. On that, I will slightly prepare, and I'm lucky because this lateral, it's much more palatal than the other one. So I have already some room in order to put my veneer. This is the prep of my veneer, as you see, before and after. And you see the prep is very, very conservative. I don't prep any area here. I don't prepare any chamfer. It is totally infinite margin, because then I will work with a bulky area in order to hide that part. And this is the way that the only situation in which I use a try-in order to understand better how to fix this veneer. But it's a very, very difficult procedure for the dentist and for the technician. Really, to get the perfect color in one tooth, it is really very, very difficult. Me, I was lucky here because it was a lateral, not a central, and also because I had space to make this tooth much thicker. And you see the screen in white that I've used in that. And this is the situation before, and this is the final results that I got in such a situation, in which you see the thickness of the gum around, it plays a very, very important role. So, I invite you to know this guy, Ignazio Loi, and his way of thinking in the BOPT preparation, in which there is no cervical area prepared with chamfer or any other kind of preparation, but the vertical prep allowed you really then to grow from the gum as you wish, and to make your profile much more bulky, and in this way much more supportive for the gum itself. Just I want to show you why I'm telling you that. Here you see three situations: a very slim tooth, a very slim veneer, just consider a normal one, or something bulky. So when the tooth is slim, or even imagine if it is prep, let's say in that way, when the patient is gonna brush, of course it will create some negative push on the gum itself, like here. And this is happen still when there is a normal profile. When you are exaggerating with your profile during the brush, you see the direction is totally different. So the longevity of the gum It's really important, an important consideration linked to the thickness of that and to the profile of the veneer or the crown that you put on that. And just one example to finish my lecture. This is Maria, 55 years old. She came to me because she saw this black on this cervical area in this crown that somebody put 5 years before. I took a radiogram and I understood that the black comes actually because, as you see, there was lack in cementation. There was an unprecision way of going. The tooth is quite short. We decided with Maria to proceed to extract the tooth orthodontically, and if instead I will find some solid tissue, to extrude a bit in this way and to go for some single crown in order that in the future, if needed, to go for implants. But now, for the moment, if possible, to save. So the first step it is to study the situation, to prepare a new temporary based on these two teeth that are much bulky. I mean, the trouble is here. So you see, I'm following this line in order to make my restoration much bulky. When I remove the crown, I understand. As you see, when the dentists, they found non-vital teeth, they go very easy to prepare, and sometimes they forget the shape. And this teeth now it's black for the reason that it was infiltrated, let's say. So I fixed the temporary, I just separated, I asked my orthodontist to start extruding, and I was cutting time by time the central until the moment that I saw some healthy tissue, and then at that moment I stopped, I removed the old restorations, I build up with the new one, and then I fix my temporary with some composite over the other teeth, and you see the gum. The gum has followed my extrusion in this way. So this is the build-up of my new situation. My prep, it is totally vertical. I don't have any procedure in this way to go with any kind of chamfer or butt margin or whatever, but it's vertical because I need to create the best ferrule effect and also the best integration with my margin with the gum. And of course, the final material will be zirconia because this is a kind of white metal that helped me really to be very vertical. But what I want to emphasize with you it is that that's the situation before vestibulary of this central. This is just after playing with my temporary and play with my extrusion. As you see, I have worked in creating a thicker cervical area of connective tissue, and this will hide any trouble coming from the black that still is in the root itself. This is the final restoration with zirconia monolithic and just the veneer of ceramic, and this is the job of my technician Daniele Rondoni, really very smart in creating the new dimension in this root with a different diameter. But as I told you, the success you can catch after years. Here we are after 10 years, and still you see the situation correct and the profile of the gum at the right point. What I like it is to emphasize the fact that if you have a procedure in your mind, you finalize the situation at the best without any change in your treatment plan. So, which are the idea regarding this last topic? Thick the gum always, as much as you can. This is just will be the best way to hide any black coming from the roots. Second, try to program always bulk restorations, because in this way you can make your veneer, your crown much more thicker cervically, and of course you can hide better any color, and you can reinforce the tooth itself. So I'm just finishing. I wanted to thank you very much. I just want to tell you that you can find us on our website, stallitaliano.org, and on Twitter, on Instagram, and on Facebook as well. I just want to introduce my last baby, the Stall Italiano TV. You can catch my lectures in this TV. Actually, we went for these 2 months in a charity. We had an agreement with the international Red Cross organizations So all the money that are coming from the Stale Italiano TV, they goes directly to the Red Cross organization. That's the reason that we didn't go for any free webinars at this time, but instead we wanted to keep all the energies to help, really to help somebody in this very strange time. And actually for you, if you go to our website, to the Stale Italiano TV, and you put this coupon code SSR20, you can get access with a special discount to my lecture, the lecture of Stefan Kubi and the lecture of Paolo Montero. And for the future, you will have a discount also in a kind of 10% for all the courses that you want to follow with us. So now donate in the future, stay in touch with us to see how it works, this revolutionary way to be online, because this is what always me and D'Angelo, we try to catch. The news are the way to evolve and not just the trouble for all of us. Thank you very much for your attention, and have a fantastic weekend, and I hope to see you alive soon. Thank you.
Thank you, Dr. Devoto, for your presentation. Please stop share your screen if it's possible. Thank you for your tips with that bulky parts near gingiva. And we have a few questions for you.
Yes.
First, what system of bleaching do you use for vital and non-vital teeth?
So just a quick second. How can I stop in sharing?
No, right now it's okay. Right now it's okay.
Okay. Sorry.
Yes.
So tell me again. Sorry.
What system of bleaching do you use for vital and non-vital teeth? It's something different, or?
No, I mean, I told you at the beginning that there are not many news in the bleaching system. Today, we have prepared, I mean, not today, a couple of years ago, in combination with one company, the Optident, we have selected one material, which is the White Dental Beauty bleaching systems, diffused worldwide by Henry Schein, because it's cool, first of all, meaning that there is a nice packaging, a Tiffany color, with a bag, with something. I mean, it gives values to this composition, because there are different percentages, so you can choose your one. And usually, I'm gonna choosing the low percentage of carbamide in order to be very safe, and because we like the fact that there are some detail inside to give less sensitivity as possible in the procedure. But as I repeat, basically, bleaching must be an opportunity. If it's not, it is an issue. So make your choice, go wherever you want. Just don't believe blind in the bleaching as the only procedure to make your teeth white.
Okay, thank you. Another question. Do you prefer feather edge preparation for the discolored teeth? And which kind of preparation can mask better than dense gingival area, that transition zone thing?
So as I wanted to tell you, the majority of teeth that we go to cover with the veneer or with the crown, they are non-vital teeth with a very low ferrule effect. For such a reason, my strategy it is, yes, feather edge, because in this way I can get the best ferrule effect. Yes, bulky restorations, because in this way I can support better the gum, I can make the tooth much younger, and also I can have much more room to put some screening inside of my restorations. And of course, in this way, I go pair, or I go to cover 4 teeth or 6 teeth. I never go for a single restoration with an indirect, if not just for an exception, let's say as the lateral that I show in my presentation, because it was a bit already palatal. But really, I mean, today, all the time, I can tell you that I go feather edge, and I try to take care very much to the commitments in between the final of my prep and the thickness of the gum.
And you use feather edge preparation. You use also a temporary crown, I think.
Of course, the temporary crown, they are the most important part. As I show you in my last case, modifying your temporaries with some flowable composite material cervically, it helps you to push the gum where you want. And in this way to create much thicker gum, and in this way to have some gum prompt for welcoming your ceramic restoration. I mean, the rule of the temporary, it is absolutely important. Of course, just we are speaking about full crown. In the veneer, instead, the solution is totally different. But I don't see any point in preparing a precise margin and then to have trouble in the longevity. This is my message.
Okay, thank you, Dr. Devoto, for your presentation, for your answer. Thank you.
My pleasure.
Hello, everybody, again. It's my pleasure to invite here in front of you the next two speakers, Dr. Silvana Canjou and dental technician Cristian Petri. A few words about Dr. Silvana Canjou. He is a specialist in prosthetic dentistry, having also a PhD degree in minimal invasive diagnostics area. The private practice is focused on complex aesthetic and functional rehabilitation on teeth and implants, using both traditional prosthetic methods and also innovative ones, focusing mostly on minimally invasive procedures. Dr. Canjou is a co-author for four books, 21 published articles, from which 5 are in ICA journals and 1 PubMed indexed review and article. She has over 55 national and international communication in the field of prosthetic dentistry, implant-supported restoration, and minimal or non-invasive oral diagnosis. A few words about dental technician Cristian Petri. In 2002, he opened his laboratory in Cluj-Napoca, Romania. He further specializes as he partakes to the courses conducted by Professor Slavicek, Master Dental Technician Massimiliano Trombin, Achim Ludwig, and many others. Since 2011, he has been holding lectures and publishing information regarding the fabrication of complex implant restoration with a focus on functional and aesthetics. In 2018, Christian Petri was inducted into the International Oral Design Group by founder Willy Geller. He is co-founder and president of Dental Initiative Romania, a non-for-profit association with an educational character. He is also the initiator of the Team Congress in Romania. For today, they have a presentation. The title is Prosthetically Guided Dentistry. What does minimally invasive really mean? Please, if you are ready, the podium is yours. Please share your screen with us. Thank you.
Thank you very much, Cosmin. I will let Silvana to start to share our lecture today with you.
Good afternoon, everybody. We are very excited to be here with all of you today. I hope you have left a little bit more of energy and patience to see our lecture. We will talk about, as Cosmin said, about minimally invasive dentistry, an actual and very debated topic. What is interesting is that we are all gathered here today because of this little virus, and we can freak out about a lot of things, and we can consider a lot of issues that are not exactly the way we want them to be. But I think we should also embrace and see the positive part of being in this situation. And one of the benefits that I see is that it truly allows us to hit the reset button in many aspects of our lives. We are most certainly living through uncertain times, and in many ways the world has shrunk. As you may see, we are all able to be here today from different parts of the world on a given Saturday afternoon. And even if Cosmin did a beautiful introduction of me and Christian, I would also like to add some little details. So I'm a Romanian dentist. I've studied and worked in Romania for 9 years. I was lucky to be part of a great team in Timișoara. And my professional life is divided in 3 main parts. The clinical part, which I enjoy the most. The teaching part, which I do through the platform learning by doing. High impact learning teaching platform, which focuses on minimally invasive dentistry teaching under the concept of interdisciplinarity. And I have also a research activity. For example, my latest article will be published this July in the American Journal of Orthodontics and Dentofacial Orthopedics. And Chrissy, now back to you.
Thank you, Silvana. As you already know, I'm a dental technician. I have my own laboratory in Cluj-Napoca, Romania. And together with my wife, we have a clinic in the same city. And I'm also an oral design member since 2018. Silvana?
Okay, so minimally invasive treatment options. We all know that have become increasingly feasible for restorative dentistry due to the introduction of adhesive techniques and restorative materials that gives us translucency and fluorescence properties similar to those of natural teeth, like, for example, Hera ceram does. But we have to know that the conventional subtractive treatment approach is gradually being replaced by this defect-oriented additive method. That means minimally preparations or no preparations. And this presentation will show you a number of clinical cases to demonstrate the working protocol for this modern approach. And this slide practically shows you what minimal invasiveness really means to us. Everybody that would like to have such an approach should have some sort of a working protocol. It can be this one, or it can be one adapted to your practice or your clinical beliefs, professional beliefs. The general idea is you should have a workflow that guides you through all these phases in order to control the final outcome. And as you see from this slide, we always start our treatment planning with the prosthetic planning, so that we always have our end goal in sight. We don't lose it. And on that note, I would like to guide you through 3 of the most common myths in prosthetic dentistry. The first says that no prep is always better. Well, unfortunately, that is not the case. We all wish to have only non-prep case, but in the real clinical life, we find them very certain. The second myth claims that no prep restoration are more aesthetics, and you will see during this presentation that that is not always the case. And the third myth says that no prosthetic restorations last forever. And on that one, I just want to say that in my opinion, nothing that we do in dentistry will last forever. So at the end of the day, we get to walk the fine line between expectations and reality, because if expectations don't meet reality, there will be a huge avenue of frustration and disappointment. That is why we have to come up with some sort of a treatment planning algorithm in order to know exactly what the best way for our treatment is. So what the best treatment route would be. Historically, preparations for restorative dentistry have varied from extremely aggressive to minimal reduction, let's say. And today we are going toward a minimal invasive dentistry era with this philosophy in mind that less is more. Less tooth preparation means more adhesion and more and clinical longevity. And in this context, I developed this treatment planning algorithm that includes these 3 main criteria: aesthetics, biology or structure, if you will, and function. Of course, having in mind that from an endodontical, periodontal, and radiographical point of view, we have no pathologic changes, or these changes were previously treated and are now stable. You may see it's a very busy decision tree. What does this decision tree do? It allows us to easily figure out if our case can go with a non-prep planning. So if our case is suitable for a non-prep approach, or for some sort of a preparation, tooth preparation. And I'm going to walk you through this algorithm. I'm going to do my best to convey a very linear process of things we have to consider when we do our decision, when we make our decision. And let's start singling out the reasons why we prep the teeth. And attention, when I say prep the teeth, I mean minimally prep the teeth. So, for example, if we have bulky dental profile, so by this type of dental profile, there is a slight chance that you will be able to do a non-prep restoration. If you have severe decoloration, if you have form and position deficiencies, if you have asymmetry in the gingival contour, or proximal caries or composite fillings that are insufficient. So these are the reasons that guide us immediately to thinking that this case should be treatment planned as a prep case. The same goes when we have unfavorable function. So, and here I would like to point out especially the intermaxillary relationships. When we have severe deficiencies in this area, maybe it would be better to have an orthodontic treatment done before we do the prosto. And if the deficiencies are not so severe, we can think of planning this case and doing some sort of a minimal guided preparation to solve the situation. And you can imagine if on top of these 2 criteria, we have no structural loss, so no wear of the incisal edges, no loss of the buccal volume, no palatal enamel loss, then we have to obtain our ceramic space somehow. And unfortunately, as you will see, not in every case we can rise this, we can do a suitable increase in the video. So that means that for sure our case will need some sort of a preparation. The other way around would be when the gods of dentistry lie and we have an adequate aesthetics, we have favorable functions, so a function that is not so severely affected. We have wear of the incisal edge and at least wear of the buccal volume. In cases of erosion, we also can encounter loss of palatal enamel. So in this case, we can immediately, as soon as we see the patient, think that this case could be solved with no prep, with a non-prep approach. We get to walk this fine line between treatment planning too extremely or too softly. We are as inefficient if we treat treatment plan too softly as we are when we treatment plan too extremely. We may fall in the trap of being either negligent or over treating our patients. We have to be aware of the fact that dental erosion and the dental wear is becoming gaining a place, let's say, in the younger generation of our patients. So there are a lot of clinicians that ignore this situation or that don't realize the severity of this situation and postpone its treatment. Either to the lack of awareness, as I said, or to the uncertainty regarding the proper course of action. This being said, nowadays we know that that when our substrate is mainly enamel, we need only these values for our ceramic materials. On the other hand, if our dental substrate is mainly dentin, we should add a little bit more to these values for our ceramic thickness. Today we know that in the posterior area, minimally invasive occlusal veneers that vary from 0.5 to 1 millimeter, made of ceramics, but not only, can be applied to correct the occlusal tooth wear, attention also with exposed dentin, in cases of normally expected intraoral forces. So basically, we know now that we can rely on these values, these ceramic thicknesses for the posterior segments. Another important thing to consider is the color of our substrate and the color that we want to achieve at the end of our treatment. For every color change, we have to know we need this 0.2 millimeters. And let's say that our baseline is an A-FEAR and we want to reach an A1 at the end of the treatment. That means, according to this rule, that we need 0.8 millimeters. Okay, let's say that a very good technician can achieve it also with 0.6 millimeters. But the idea is that whenever we want to make a big color change, we need to have more space for the ceramic material. Another important aspect that the vital substrate, the vital teeth as striatate differ from the non-vital teeth because non-vital teeth often have a severe or a strong discoloration, and that is translated into our clinical life that we need more space for the ceramic material in case of non-vital teeth. And we have to be careful when we have a case that has also vital and non-vital teeth. We always have to have a bigger place for the ceramic materials at the non-vital teeth. So, what is the big picture? The big picture would be that it will be great to plan 2 times so that we can do correctly 1 time. But what about thinking 3 times? And for those of you that would like to approach this type of minimal invasive dentistry, you can do it safely because it's a reliable treatment option. As you see, we have also studies that show us that this type of restoration over a long period of time, you see here up to 11 years, have no technical or biologic complications. and that is valid for posterior segments, but also for anterior segments. You see we have a success rate here of 100%, so you can rely on this type of treatment. And for those of you that are interested, the actual literature, so there is a lot of studies that are published recently that certify all this data. Good. And having all this in mind, I would like to introduce you to our first case. As you can see, we can notice from this first slide that our patient has an incisal wear of the teeth, and what is more obvious is that in the rest position he doesn't show his teeth. So if we take a closer look intraorally, you may see that not only the incisal margin is worn, but also the cusps of the canines. And if we take a closer look from an occlusally point of view, we may see at the premolar level and at the molar side some extensive wear with exposed dentin, some fillings, composite fillings that are also worn out. You may see some spaces between the teeth, but that is not necessarily bad because it helped us at the end to nicely reproportion the teeth. You may see that we have no loss of palatal enamel. That means this case is not an erosion case, but it is a primarily dysfunctional case. So it's a primary dysfunction that we're talking about and not erosion. The same goes for the lower jaw. You may see here, again, this the exposed dentin, the wear composites, and the spaces between the teeth. So if we look at this case through the eyes of our algorithm, I think you agree with me that it's a very straightforward case. That's why I chose to present it first, so that I can better explain to you how this algorithm goes. So from an aesthetic point of view, you may see we have a nice substrate color, we have flat dental profile, we have places between the teeth, so we have an adequate aesthetics. The function was acceptable, so we didn't have severe occlusion problems. We had additionally to these two parameters, we had the wear of the incisal edge, and we have a loss of buccal volume. That is how we know that from the beginning that this case we can treatment plan it as a non-prep case. And we will show you how we did a therapy for this case, and after that I will show you we will show you two more cases where we apply this algorithm. So we started up with an aesthetic wax-up, and it is very important to know that we as dentists have the responsibility to send in the lab all the information the technician needs in order to obtain this, to create this aesthetic wax-up. As you see, we lengthened the teeth, we closed the spaces, we redid the occlusal aesthetic plane. And it was necessary this situation to test into the mouth to see if that was the good direction to go, and everything was okay. We went forward with the functional wax-up. We did an arbitrarily video increase so that we gain space in the posterior segments. For the restorations, we divided the space gained between the two arches, and in front we were able to remake the morphology of the frontal teeth, lower teeth. Practically this increase in video that we do it mainly to gain space, as I said, for our restorative materials. Of course, we have some extra advantages with this procedure, and you can do it without any fear because as you see, we have here a systematic review that included I think 902 articles, and which states as a conclusion that this is a safe and predictable procedure. Of course, we can have some disadvantages or secondary effects, let's say, for this procedure. For example, one of the most common negative effect after increasing a video can be pronunciation problem, especially by the S sound. But you have to know that this normally the patient normally adapts to this situation in 1 and up to 2 weeks. So as you see, other studies are also available that show us that no permanent alteration will be done to the patient's TMD situation. So it's a safe way to go. We did also the functional mock-up. I use this Teflon tape to protect my gingival niche. I often do this spot edge technique so that my functional mock-up lasts better. The same I do also in the lower jaw. And now we have a functional mock-up that I usually prefer, and I would usually prefer that the patient wears this mock-up for minimally 2 weeks. It helps us to see if the aesthetic and functional parameters we calculated at the beginning can be followed for the final restoration. It gives us the chance to check with the patient if he can function, if he can speak, if he can talk, if he can eat, if he likes it. We can test out if our increase in DVO is correct or not. So it helps us a lot. It's a great tool to use in the clinical practice. So after 2 weeks of wearing this mock-up, after the waiting period, if everything goes well, and usually it does, you go on with the treatment planning, with the implementation phase, let's say it like this. And for this case, we decided to restore this affected dentition with no prep restorations, basing ourselves only on the adhesive protocol available nowadays. And as you may see, I just rounded the incisal edges. I just eliminated with a disc the aprismatic enamel, so that at the end I will have an increased bone strength and no problems in the adaptation of the final work. So again, the lower jaw, we did the same. I just rounded the sharp edges with a disc, and I prepared the sulcus for the impression. For this case, I opted for a conventional a polyether impression for both arches, and I sent all the information to the lab.
Thank you, Silvana. Back to the laboratory now. We already know the final destination of this case because we have made the wax up, and as the dentist used the wax up as a guidance, we also use this end information as a start point. Why start point? Because we do a cross mounting, and from this point, we will use the working models combined with the wax up or mock-up models. Second step is to mount the models, the master models of the upper jaw with the lower wax up model into the articulator. And from this point, we go to set into the articulator in the same position the lower master model using the bite registration done by Silvana. Next step, which is really important into the laboratory, I create a silicon index of the incisal margin of the upper wax up or mock-up. Why? Because I will transfer this information into the articulator with the upper jaw master model. And with this information, I recheck the position of the incisal margin. I can see where is the incisal margin of the tooth or of the teeth and where I have to be at the end. Beside the phonetic and aesthetic reason is important. When I start, I already know what I can do for this case and what I cannot do for this case. we see that there is a lot of space in the incisional margin, but when we go to the next slide, and we use also a vestibular silicone index, I realized that I do not have a lot of space for structure and on top to build up the ceramic. The approach is to use lithium disilicate structure for this case, even if that we could use feldspathic veneers here. Now the question is, if I want to use lithium disilicate, can I use press ceramic, or I can go to mill CAD/CAM blank ceramics? When we have done this case a few years ago, the laboratory options regarding mini ceramic blanks were limited. And that's why I decided to do press ceramic. But now on the market, we have a lot of companies, a lot of producers who produce this kind of press ceramic or blank ceramics. And the question is, what should I use? Here are some tips and tricks. Is the fluorescence important? Value also it's important or not? You can see a really good comparison between a natural tooth, extracted tooth, and a pressed ingot from different companies. For this case, I decided to do all the veneers by hand, so I choose to do it analogically because of the lack of space, and then to press all the veneers. After pressing, divesting, and working the veneers, you can see left and right that there is an extra space in the incisional margin that I can use. So I decide to use this space to build up the ceramic for a better aesthetic. In the posterior region, the restorations were monolithic and just 3D stained. Why? Because I have a better strength. Important to know that the glaze parameters are totally different for the monolithic works compared with the build-up works. And when we finish the case, it's important to recheck the occlusion, to recheck the contact points, and then when everything is ready, we can send it to the dentist or to the clinic.
So here we come again in action, the clinicians. Of course, I recheck everything that Christy sends me, and I check it also in the mouth through this process of try-in. I usually evaluate if our plan corresponds to the end result, and usually that is the case. So everything looks good, and we go ahead and adhesively cement these restorations. I usually do it under rubber dam, so I always do it under rubber dam isolation. Very importantly, I recommend that you always check the fitting of the ceramics after you have isolated with the rubber dam, so that no malpositions occur. And then I cement tooth by tooth the restorations, and this is the comparison between the initial situation and the final job. You can see a very beautiful texture that Christy and colors that Christy managed to do to this case. For this case, we had, as Christy already mentioned, and we do it often, monolithic ceramics from bicuspids to molar, and partially layered ceramics or feldspathic ceramics from cuspid to cuspid, and that goes also for the lower jaw. So everything looks nice and stable. You may see how beautifully we managed to reconstruct these occlusion planes by increasing the DVO in this patient. And remember, we did no tooth preparation here. And the final occlusion check, usually the final occlusion check, I do it with this very thin occlusion paper, 8 microns occlusion paper, that in the frontal area, and you see that in the frontal area we have no contact at this thickness. As for the lateral areas, so from the canine to the molars, we have strong contacts with this very thin occlusion paper. And this is our final outcome. The patient was happy about it, but it was no surprise because we already know from the planning phase where we wanted to go. So everything was controlled. And this is a recall in 2020. Again, for the moment, the things look nice. Hopefully they will stay like this for a long period of time. And that being said, I would like to introduce you to the second case. You may from the start notice that we have an initially flat smile line because of the excessive wear in the incisal margin and cusps of the upper jaw, of the teeth from the upper jaw. And if we have a look closely in the mouth, you may see that the functional movements, so protrusion and lateral protrusions, still function, but I'm assuming that not for long. So we are very close to having unfavorable contacts in the non-working spaces. That's why we know from the start that we have to do something about it. And if we have a look from an occlusal perspective, you may see this huge dentin exposure in the central incisors, as well as in the molars and premolars surfaces. All the occlusal surfaces are being flattened. So that is a real problem for a young patient. We have to do something about it. And this is an initial X-ray evaluation in 2017. I want to point out that the patient is a dentist and also our friend. And of course, he had a bunch of wishes to be completed. One of them was no prep, so he didn't want any preparation to be done to his teeth, whiter teeth, monolithic ceramics in the posterior areas, as you see. And this is the seated condylar position. You notice the very little space in the posterior quadrants and a great space in the anterior area. And if we were in the normal conference room, I would ask you, what do you think? Could the video here be a little bit more increased? And I will answer that for you, no, because even if we add, let's say, 1 millimeter in the posterior area, that will mean 2 extra millimeters in the frontal area, and that is really impossible. So more than this, we cannot increase the video. And the reason is that this patient has a hyperdivergent profile. So yeah, we cannot do it. More than this, we cannot do it. So Christy, back to you.
Thank you, Silvana. And now back to the lab with a non-prep case, full mouth, and must be done with monolithic lithium disilicate, as you have seen the request from the patient and of course also from the dentist. Silvana did also intraoral scan using a 3-shape scanner of the initial situation. As we can see the space also on the digital workflow, on the first molar, on the occlusal surface, we have 0.3 millimeters. On the second molar, we have no space. So when we have 0.3 millimeters for both of our tabletops on the first molar, it's not little, it's a lot of, it's not enough to do any kind of restoration. What can I do in this case? If I check the producer indication, as also Silvana told you, I need at least 1 millimeter for each tabletop. So together will be 2 millimeters. If we increase the DVO with 2 millimeters in the posterior region, yes, we can do in that moment, but we cannot do this case because also Silvana told you why. Literature is showing us that we can be on a safe side on 0.8, 0.6 millimeters for a tabletop. But also, we need space for both of the tabletops, not just for one. And we still do not have this kind of space. Back to the idea, no prep, no increase of the DVO, but to do my works in lithium disilicate at 0.2 millimeters. Can be this done? What we can do? Solution to do a wax up, this time digital, and then we'll see after. As a start point, we import the intraoral scanning done by Silvana, and we start to do the digital wax up. During the digital steps, it's very easy to check with the tools that we have the limits of this case and the options and possibilities of the materials. As you can see, there is a lot of space for the central area, but there is no space on the first and second molar in the occlusion. What we can do, the limit option was to increase the DVO with 0.9 on the articulator, but also in this moment on the second molar, we have only 0.4 millimeters for both of our tabletops. So still 0.2 on the second molar, 0.2, 0.3 on the first molar. Still a lot under the minimal thickness that I need to do this kind of case. The wax up, it's a additive digital wax up. When we do it as the first time, everything looks amazing. And we think that all will go easy and will not have any kind of problems. But as Silvana told you when she started the lecture, let's think 3 times, plan 2 times, and just do it, if it's possible, just 1 time. Silvana, back to you.
So after I received the digital wax up from the lab, so the printed models, I mean, I did this normal functional mock-up that I always do. And it helps us, this preview that the patient had, helped him decide that he's okay with having a little bit thicker teeth as normal. As you can see from a functional point of view, we were able to achieve our goals. So these are the images with the prep teeth, let's say. It was actually like the first case, no prep. We just rounded, I just rounded with the disc, the incisal edges and the sharp margins. And these are practically the teeth before scanning them. I chose to scan the case, but so that I was sure that Christy could manage this case, I also took 2 impressions, conventional impressions, and again I sent every information that I had to the lab.
Thank you, Silvana. We know that we can manage the analogic protocol for this kind of cases without any kind of problems and with the success at the end. But we know also that thin occlusal ceramic onlays are very fragile and they may fracture during wax up or analogic, even on digital workflow. That's why, what can I do in this kind of cases? Should I choose to do it analogic? But we all want to do it digitally because it's faster. Can be done digitally, can be done in an analogic way. How do I take my decision? We have, as you can see, no prep teeth. The image on the left, it's a non-prep molar from of this case of this patient. We have also to change the color. This was one of the requests from the patient. So we need extra space, but we have no prep teeth. Also, as you can see in the middle of the screen, we have areas with undercuts. Can I insert a crown, a V-shaped crown on this kind of natural teeth? Silvana must prepare the teeth. I will not do this kind of case. But
the answer is no.
At 0.2, 0.3 millimeters, and without no prep teeth, it's impossible to mill a crown in the digital workflow. And the options that I have received from a friend of mine, Ciprian Panaite, who's working in Bucharest, and I want to thank him for this information. This kind of approach was done by August Bruguera in 2016. The option was to duplicate the teeth and to do them from investing material and build the thin crowns, the thin veneers in wax directly on the investing material without removing them from the model. We check the guidance in the way that every tooth has his function. After that, step by step, we create the final wax up, the final shape of the teeth, 100% morphologic and 100% functional. We are not always fully digital, even if we want to do it full digital. Our brain and hands are the most important tools today, even if the digital tool is one of the biggest tools in the laboratory today. So my idea, select your case, select your tools, and you can win. Going next, one tip and trick is to know that the wax weight, because now when we invest, we do not have only the wax, we have also the investing material inside of our crowns and veneers. Also, another tip and trick for today, it's the pressing protocol is really important. Why? Because we have this investing material inside, and my recommendation for you is to do a test before any kind of this case. Also, when we start to divest the pressing, you can see that the veneers are really thin, and you have to be very, very carefully. I recommend you to use as a start 110 microns aluminum oxide, and then to finish the case with glass pearls. Now we have thin veneers, we have really thin crowns. But even if they are not on the prepared teeth, we need to check the fitting and to be sure that the crowns or the veneers are really good and we have no issues. If we check those two images, an overlapping of the natural tooth from the model with a non-prep crown show us the replaced volume that we have to change. For example, on the cusp, we have 0.4, 0.3, and on the rest of the surface is just 0.2 millimeters. Pay attention also after pressing to the tools that you are using. It's important to know the speed and the type of the grinding tools that you use. In this way, I was able to obtain, using this kind of protocol, I was able to obtain really thin crowns, 0.2, 0.6 millimeters without any kind of issues. But let's remember that on the second molar, we have had 0.37 millimeters for both of our molars. As you can see on the right side of the screen, on the red circle, we were able to obtain 0.16, 0.18 millimeters for each, let's say, V-shaped crown or a V-shaped tabletop. With this procedure, we can obtain incredible thin restorations without any kind of problems. Now that we finish our monolithic restorations, it's time to glaze them to have a really good aesthetic result, even if they are monolithic. Regarding the glaze protocol for the monolithic restorations, I can share with you two types of options. First, it's called the three-step technique. When we apply on the first step the stains and the colors on our restoration, we do the sinterization. Then the second step, we do the correction, color, or the stains. And at the end, with the final sinterization, we do the glaze to cover everything and to be sure that we have the colors on top. Second option that I can recommend you for monolithic kind of restorations, we can do this all at once. We apply the colors, we apply the glaze in the same time, and we just do one firing. After we have the final restoration ready with glaze and stain, you can see that we have the non-prep teeth. We recheck them all the time on our non-prep teeth to be sure that the fitting is correct, the occlusion is correct. But also we have frontal region when sometimes the request of the patient or the request of the dentist, it's higher compared with the posterior regions. And I prefer to do a cutback or to do just thin veneers and start to build up ceramic. For the example, you can use on the Haas ingots, you can use Heraceram 750. And my recommendation when you start to build up ceramic on lithium disilicate, try to use all the time one-time build-up, one-time sintering technique. Why? Because in this way, you are able to keep your value on your works and don't lose it and obtain gray shaded restorations. One good tip and trick is you can see on the screen the firing protocol that I use for one-time sintering, one-time build-up technique. Now we have the finished works. They are ready. We check them again on the model. We check them again on the dies. We check the occlusion. We check the function, the contact points, and we are ready to send them to Silvana with the mention that, Silvana, take care, please. They are really thin, 0.2. They are monolithic. Be careful.
Yeah. So with that in mind, I went on, of course, with my normal protocol, but I was very careful with your restorations, Christy. I managed to cement everything in place without breaking any one of it. You may see, again, we have, like Christy told you, monolithic ceramics in the bicuspids and molars, and partially layered ceramics for the frontal area. We have double veneers for the central incisor and lateral incisors, and V-shaped crowns for the canines. The same protocol also in the lower jaw, so everything was cemented carefully. When we look at the occlusal planes, we can see that we managed to re-establish them. We re-established the morphology of the natural teeth, and you may see also the protrusion and lateral movements that are okay, and we can evaluate these movements also in this short video. You can see we obtain a lot of space for the non-working areas so that our patient can function very good for the next years. Do you think that this treatment will last forever? I don't, but for the next years, I'm sure it will be a good one. So our final result and comparison between the initial situation and the final outcome were recalled in 2020, some months ago, before this corona crisis started. So this is a radiographic evaluation from some months ago. Everything looks nice and stable. We are happy about it. But if we were to look critically at this case, I would say that the volume of the upper teeth is a little bit too much. And when we put this case in the context of our decision tree, you may see that even though we had adequate aesthetics and some sort of a structural loss, so the wear of the incisal edges, that was not enough to plan this case as a non-prep case according to our decision tree. So if I would have followed this decision tree that told me that I cannot increase the DVO, so I have an unfavorable function there in occlusion area, I have no loss of buccal enamel, I have no loss of palatal enamel. So all these phases guide me to the idea that this case should have been a prep case, a minimal prep case, and if I would have ignored the wishes of our patient, I could have prepared maybe a little bit of the buccal aspect of the teeth, let's say 0.2, 0.3, so that we reduce the buccal volume. And for the posterior area, maybe an orthodontic intrusion was suitable, or just to reduce a little bit of some of the occlusal areas in order to minimize the space needed in the front for the palatal veneers, so that at the end we could have had slightly thinner teeth. Okay, that being said, I want to walk you through the last case of today, and you can see this that from this picture it is clear that we have severe structural loss of the remaining teeth tissue. We have failing prosthetic reconstructions. We have over-prepared teeth. So basically, it's a complicated case. But even what I want to say, that even these sort of cases, you can approach with a minimal invasive treatment by relying very much on the adhesive techniques nowadays in order to maintain as much structure, healthy structure as possible. And that being said, again, having a look at this case through our algorithm, through our decision tree, you may see, of course, that aesthetics was inadequate, that function was not favorable, and only these two elements guide us directly to thinking that this treatment, this case will be will need some sort of a preparation, even if we have so much tooth structure loss. So we have incisal wear, we have buccal volume loss, we have palatal loss, so palatal enamel loss. So even though we have so much loss because of the aesthetics and the function, we know it directly, immediately, as we look at this case, that we will need to have some sort of a preparation. And this is our functional mock-up in 2016. What does this functional mock-up for me? It tells me what my end restoration, what my final restorations will look like. So I know the tooth length, the tooth position, the volume of the tooth, and what do I do next? I calculate how much ceramic thickness I need for the final restoration according to the criteria as I mentioned at the beginning of the presentation. So I know exactly how much I need to prepare from this mock-up in order to gain the perfect space for the ceramic. Not more, not less, just the perfect place for space for the ceramic. And I did that, and this is the result after preparing through the mock-up. You may see that some parts I just barely touched the teeth. Some parts, like for tooth 2 I reduced a little bit more. The next step was to remove the remaining composite material from the mock-up and to reconstruct the teeth with a composite filling, and in order to be able to make an adequate and optimal, let's say, preparation design. And you may see here different preparation designs from veneer designs to partial crown designs to crown designs. The same was also done in the lower jaw. Here is a combination of no preps, of minimal prep or prepless, if you will, of classical preparations for the teeth that were already prepared by another dentist before me. So again, I gather all my information and I send it to the lab.
Thank you, Silvana. We already have seen the protocol for analogic and digital, and always it's important to know the final destination. That's why we use the information from the wax-up or for the mock-up into the laboratory. We scan the wax-up, we scan the prepared teeth, or we import them directly from 3Shape. And with the digital steps, we create really fast our shapes, and it's really easy to check and recheck in the same time the occlusion and the shapes and the function. I'm sure that the occlusion is fixed because we work with monolithic restorations on the posterior region. And as you can see on the bottom area of the screen, from CAD to CAM, and with the touch of a technician, we can copy the wax-up, the digital design, and then we can create a really great work in no time. All those STL files that we have now, we can mill them. For example, those days from monolithic ceramic blanks. For example, amber mill, and we can mill really fast, the wet milling. We have a lot of options today, and why it's so nice, this new material, not only because we can mill it wet and fully anatomic, is because the first strong point that I can say about the amber mill, that it's very stable during the milling. And as you can see, the margins are really thin, the veneer is really thin, and the margins are perfect after milling, and we have no issues. As a tip and trick for dental technicians, and not only for them, also for the dentists who use chair-side CAD-CAM, just be careful how you cut the spruce after milling. If you don't have a wet option, then after you cut the spruce, it's important to use a stone wheel and remove the excess of the sprue in order to obtain the final shape of the crown or of the veneer. And then even if we were able to mill them at 0.4, 0.5, 0.3 millimeters, with the proper tools or with the silicone wheels, we can thin the edge of the veneer under 0.2 millimeters. Also, another good tip and trick for the technicians or for the dentist is that you can polish mechanically the restorations in this moment without doing the final sinterization. As you can see on the bottom of the screen on the presentation, there is one premolar. Left side it's polished, mechanically polished. Right side it's exactly how it looks after grinding by the machine. And as I told you, now we are able to mill those kind of lithium disilicate veneers or V-shaped crowns or even crowns really thin. We can go up to 0.3 millimeters. But even so, with the new tools, we are able to thin this kind of veneers to a knife edge up to 0.1 millimeter, even under 0.1. So in my opinion, even with lithium disilicate veneers or restoration, you can do really nice and good veneers. Another tip and trick for today, when we use this kind of new blanks from amber mill, is that they have a unique feature. From only one blank, we can obtain 4 different opacities, just increasing the temperature. If we go to the next slide, we can see that, for example, if we want to have an high translucency crown, the HT codification, we do the co-firing at 815 degrees. If we want to have a higher opacity, because our veneer or crown is too translucency, have too much transparency, we can transform our work by rising just the temperature at 825 without remilling or redoing our crown. So it's fast, and we can do also chair side, this kind of technique. If we want to obtain a medium opacity veneer or crown, we just go into the furnace, we increase the temperature at 860 degrees, and we have the final result. But attention, this procedure is irreversible. As you have seen in the first 2 cases, I was analogic. Now I want to be digital because the case is letting me to do this type. I have enough space, but with the help of the digital libraries, it was really easy to create the occlusal shapes of the restoration. Compared with the second case, where everything was done analogic, here I was faster. And everybody can do this kind of case, just copying the shape of the teeth directly from the library. When we have the STL files, we mill them as you have seen. And then using a golden powder, we can check the shapes to be sure that the morphology is in the way that we want or in the way that we like. Next step, at the end, is the customization of our monolithic restorations using the 3D effect or the 3D technique for the stain and glaze. Full monolithic on the posterior region, no risk of chipping, is the kind of restorations that I like to do. But let's see few steps how I can create from a monolithic restoration which has just one color to obtain a 3D effect on top. Today, using the new stains and shades from Mayo, which is not glazed, actually it's a liquid ceramic, we can obtain really fast, realistic and natural teeth because it's easy and everybody can do it. You can see the steps using different kind of colors and the shades for this kind of restoration. This protocol with monolithic restorations goes perfectly from premolars to the molars. But in the frontal area where we have or where we want to have a better aesthetic, it's we recommend to have a build-up restoration. As you can see, I always like to do one-time build-up, one-time bake technique for the same reason that I told you that on the lithium disilicate restorations, when we have a substructure of lithium disilicate, we don't want to lose the value of our end restoration. Even with this protocol, you will see that we can obtain a really good color with internal effects. And I consider that the protocol or the procedure, it's offering you a lot of possibilities. But in the same time, using the protocol of the cross mounting, when we have wax up or we have a mock-up, when we have a silicone index with our wax up, and with the one build-up technique, we are able to achieve the perfect and repetitive position of the incisal margin. In the same way, we are sure that the function of our cases is exactly as it was on the wax up or on the mock-up. So with the help of the digital tools and the protocol that you have seen for those three kind of cases, we can be precise, we can be fast on the posterior areas using the digital workflow. And with the help of the good knowledge, we are able to be unique on the frontal areas where we need to do more aesthetic, or where we can do perfect natural teeth, not just made by the CAD/CAM. At the end, with the help of the polarized light, you can see the internal effects that creates those kind of unique restorations.
And with that being said, I just want to show you some radiographic images from before the treatment and from some months ago, again 2020. Please have a look of how nicely this ceramic work that Christy did integrates with the soft tissues. And I would like to say that this type of treatment approach was a really life-changing one for our patient. So we just want to conclude with by leaving you with these big recommendations that should help you to be as conservative as possible, to maintain as much as possible the biologic tissue of the patient, but at the same time to obtain aesthetics and function that will last long. So in order to be predictable, we recommend that you follow these recommendations. And that being said,
I have another recommendation for all the dentists. Now, because it's the coronavirus, you have one more reason not to prepare the teeth. But using this protocol, you can see that you can approach all kind of cases using this type of protocol, not only for minimal invasive cases.
Clearly, I don't see myself upon that list. She said, where you wanna go? How much you wanna risk? I'm not looking for somebody with some superhuman gifts, some superhero, some fairy tale bliss, just something I can turn to, somebody I can kiss. I want something just like this. I want something just like this. Oh, I want something just like this.
And this being said, we would like to thank you all for your patience and for your attention today.
Thank you very much.
Thank you both of you for your presentation. Very demanding cases with very good results and indeed minimal invasive. About question and answer, I saw Silvana, you put a question and you answered too, like video. That's one of the problem for this online congress. You don't have the contact eye with auditorium.
Yeah,
About exactly about the question from the auditorium. What material do you use for making the mock-up?
Normal provisional materials. So I use many companies, many different provisional materials, because I find that every product has advantages and disadvantages. For example, I don't know, when you have a dark substrate, when you have a deep decoloration, I like to use 3M because it's a very opaque composite material. When I have very thin veneers that, or very little preparations that I did, and I want to that the mock-up looks very naturally, I use DMG provisional material. Or Voco, again, I like a lot. So I vary these materials according to the teeth that I have and to the thickness of the mock-up. I hope I answered good to this question.
Yes, sure. Thank you. And one more question. I think it's for both of you. How do you register the scan and transfer the info regarding increasing the video in the digital workflow of a full mouth rehabilitation? How do you scan and transfer the info regarding increasing the video in digital workflow?
If I may answer on the lab side, there are different procedures depending on the software, design software that you use, and also on the scanner that you have in the laboratory. But to be short, to be fast now, it's that we scan the mock-up, we scan the prepared teeth, and then we overlap everything. It's important to have as many points possible, so the software or the manual alignment can be done without any kind of issues or errors. And if we receive them from the dentist, from the intraoral scanning, we do the same thing, except that we do not scan again the model or the mock-up.
And if the question were referring to the initial situation, so before we do the wax-up and the mock-up, I usually scan the seated condylar position or the centric relation, if you want to. And there are some cases like the first one where we increase and most of them are like this, we increase the DVO arbitrarily, only with the minimal space we need for the restorations. And there are cases like the second one where we didn't do any additional increase of video. I just scanned the CR position, so the seated condylar position, and from the first contact in that position, we did the rest of the mock-up, let's say the wax-up and the mock-up. So basically, I always scan the intermaxillary relationship that I want to have. So either centric relation or maximal intercuspidation, whichever you work in. And after that, most of the cases go with arbitrary increase. So the technician increase the video with the thickness for the future ceramic material, the minimal thickness that he needs.
Thank you for your answers.
Mm-hmm.
No more answers for you. Thank you for participating at our Congress.
Yeah, it was a great pleasure as always. Hopefully next year we see us also live, because human interaction is always better. in my opinion.
For sure, next year. Yes. Thank you again. Thank you.
Thank you, Silvana.
Thank you, Pretty.
For all participants, please stay with us for a few minutes, for a few seconds. We have a closing ceremony in a few moments, please. Don't leave this whole one. Thank you.
Bună tuturor! Cred că suntem live. Bine am venit la closing ceremony. În primul rând aș vrea să vă mulțumesc tuturor pentru participare la acest eveniment deosebit de satisfăcător, să spunem, pentru toată lumea. A fost o provocare să revizuim într-un termen atât de scurt participarea noastră. Now I will start in English, and I would like Raresh not to move and not to talk over there because you are overlapping me, so stay a little bit quiet. I would like everybody to thank for participation. There have been 3 amazing days, amazing for everybody. It was a challenge for SSCR to prove itself once again that it's a leadership in teaching, and not only in Romania, but now all over the world. I would like to thank all the team, and you see now here part of the team. I would like to thank the chairmen of these days. It was pretty demanding, and I have to say maybe more demanding than in a normal Congress. I will introduce each of them immediately, and I would like to thank the team behind, and you see them in the right bottom corner, Andrea, Darius, and Raresh you already know, and Georgiana. Thank you. And I would like to thank also the team of My Connector. They were our partner for technical part this year, and not only this year. I would like to invite Professor Verlan to say a few words at the beginning.
Thank you very much, Florin. Good day, everyone. I think the most important thing that comes to me in mind right now is that a couple of months ago, each one of us here present would never thought of having to deal with such an event and with such a challenge. Simply said, we did it, and I think we did it well. And let me be very honest and say you did it, because the team of the SSER, the team of My Connector, our friends and colleagues here on screen, and especially the participants, which deserve very special appreciation for sharing with us these 3 days. It was something new. Maybe in 1 year or 2, it will become very usual. I'm not sure if it's okay or not, but this event proved that it's possible, and not only possible, but very, very high in quality. Therefore, I would like to thank all the speakers who shared these days with us, all the participants, and the visible and especially the invisible team who made this event possible and made it in an excellent level. Thanks a lot to everybody, and I'm waiting to see you at the next event. Nobody knows the way it will look like. Things change, but it certainly will take, and we will be there. Again, thanks to all of you.
Thank you. I have to move. My battery is very low. Being an online event, I have to say that we have a lot of details regarding regarding participants, and the number of participants it was pretty amazing. We'll follow with numbers on each course and days and the whole event. But I have to tell it was like in a normal and conventional congress. I would like to invite the lady which made us look more beautiful these days, and I'd like to invite Smaranda to say a few words. Smaranda.
Yes, thank you, Florin. It was an honor again to be here with you. I hope everybody enjoyed this event as I did, as I felt my speaker when I moderated yesterday. There was a little kind of emotion for each speaker. Everybody felt special these days. And I remember, Florin, I emailed you just 1 month ago, and I asked you, what about an online congress? It was amazing because you succeeded to do it so good and so quick. There is also plus and minuses in every endeavor. I think it's fantastic that we can have an online education so efficient. But of course, everybody misses a lot the human touch and our gatherings, and everybody hoped for that next year will be all together. However, I hope everybody enjoyed it. I think it was fantastic, and I really hope that next year will be as great as ever. Thank you, Florin, and thank you, everybody.
Thank you, Smaranda. I don't know if I have to say that I want to repeat this experience, because nobody wants to repeat the whole experience, not the Congress. But for sure, it was an experience itself, this Congress, and it will be memorable. My colleague, chairman from the first day, Bogdan, a few words.
Yes. Hello, Florin. Hello, everyone. I also like to thank the speakers and the participants to attending this meeting. I'm glad that even in these conditions, we had a lot of new and valuable information. So we gain a lot also in these strange times. I don't know, I had 3 amazing days in this new online format. How about you guys? How was it for you?
I've seen so many sunrises these days, because for me it was 1 o'clock in the middle of the night every opening of each day, and it was an experience, I have to admit. How was for you, Alex? So the chairman from the second day, Smaranda's colleague.
Yeah. First of all, I would like to thank everybody. First, the team. We have a great team. We knew it. We are together for 17 years. So 17 years ago, I wouldn't have thought that in 2020 we will have this unusual way of meeting ourselves, because we are really close friends in reality. But life gave us a different approach and a different chance to be here. And then I would like to also thank the audience for trusting us. I was very impressed of the number of attendees, and this shows that basically we are trusted. Either we are live in flesh and blood or online. But honestly, as Florin said before, I would just hope that all our next meetings will be live with flesh and blood. I miss the discussions in between our breaks, and also the party and or our time spent together. So thank you, everybody. It was a great experience, but I just look forward for our usual old-fashioned experience in the future. Thank you.
Thank you, Alex. We have two Cosmins today, and I will start with Cosmin Dima. How was the experience for you?
Hi, Florin. Hi, everybody. The experience was very interesting. We know we all live in a different world, and when you are living in a different world, everything is new. And when you are facing with something new, you have a lot of new conditions, and sometimes it seems that it's impossible to do it. But I want to congratulate you all for making this possible. Congratulate you, Florin, because you succeeded in such a short time. And we know that we can adapt when the life and our world is changing. If you don't adapt, you can disappear on the market. And you did it so well. And I have to admit that at the beginning, I was a little bit skeptic that we will have such a great success. To have 1,700 participants online on such a congress, it's amazing. So I want to congratulate you, congratulate all the team, the technical support, and everybody here. And hope that next year and in the next years, we will see each other live. Thank you.
Thank you, Cosmin. We had a lot of meetings before the live, and we tried the technical details. And of course, it came up one idea to record everything and to make it seem live with the speakers, because you had no emotions there. But we like the challenges, and then we decided let it make it very live, and let some small details and small maybe mistakes sometimes make it live and make it funny. And I will invite Cosmin now, the last speaker. I have to say that in the morning I laughed a little bit, but then you catch up very, very fast, and you became very serious. Few words, Cosmin.
Hello, everyone. Hello, Flori. Hello, everyone. It's a great pleasure to be part of this team. Like Florin says, in the morning, I move my chair like this, and he told me, please stop, don't move the chair in private message. Yes. About online congress, I think the speakers miss the contact eye with the auditorium, with the participants, because they put the participants can put question, and the answer will be focused for the cases. We hope for next year the Congress will be like the last year, live. And we are waiting for all participants on our next events. And we wish you all the best.
Thank you, Cosmin.
Thank you.
And at the end, I would like Raresh and Andrea to say a few words also.
Yes, I had the easiest job. I was just sitting on your chair, actually. Florina, I took your chair from the office, the most comfortable chair in the building.
But we are not moving.
You reached next year, Raresh.
I was just having discussions with the great speakers and companies. For me, it was a pleasure. Yeah, I think the most difficult was for Andrea to manage everything and emails and phone calls.
Yeah.
I think for Andrea and for Darius, if Darius is over there, I think it was a little bit easier because I was not there, and I think they were more relaxed.
How was for you, Darius? How was for you?
It was very interesting and nice, but me and Andrea, we continue the work next week.
The work never stops, Darius. Never stops. Yeah.
Florin, if you like, I would like to add something.
I would like to thank Florin because he kept me away from the fridge for 1 month.
Yes, indeed.
Thank you, guys. Thank you all.
2 more words, Florin, if possible.
Sure.
You gave me an idea. What you said remembers me of a very well-known song. You know, those who are a little older, like me, remember this song very well, but I think everybody knows it. It's called Life is Life. Life is Life might be the motto and the song for this event, because it was live and it had a lot of life. Thank again to everybody.
Thank you all. And with this, we're closing officially the 17th International Edition of Aesthetic Dentistry Congress. SSCR, I don't know if I have to say Bucharest, because we are all over the world. So see you next year. Stay healthy and enjoy the life. Bye-bye.
Bye.
Bye.
All the best.
Thank you.
Bye.